of bowel gas, and you see it really in the rectum by 24 hours of life. So if a baby is being imaged quite early and you don't see gas within the small bowel, you're not going to call it bowel obstruction, but you're just going to have to correlate it with how old the child, or the time from birth and how old the child is. And from radiology assistant, it has given you a very nice, helpful table of the timing of progression of bowel gas. So just remember, by 24 hours, you should expect to see some gas in the rectum. It is hard to differentiate in neonatal plain films on what is small and large bowel. So we never try to say it. We just tell them that there's bowel, where the bowel gas pattern is and how it looks in what distribution. And when you say dilatation, it's always when the bowel wall diameter is wider than your vertebral body width, and normally that of L2. So if it's wider, you say it's dilated. If not, it's just unremarkable. Okay. So number of causes, which we'll go through them today, of neonatal bowel obstruction. And upper GI causes include your duodenum, such as atresia, stenosis web, you get malrotation with volvulus or without volvulus, vaginal atresias, ileoatresias. And then for lower GI obstruction, you've got your anorectal malformation, and hopefully this is something that you can see. The surgeons will tell you about it when they do their examination, because it will look a bit different down there, whether there's anus or not. Hirschsprung's disease, Meconium ileus, Meconium plug. We'll talk about the difference between the two, and of course, just show you some pictures of colonial and ileoatresia. Okay. So main thing is that your upper GI obstruction tends to be presented with vomiting, of course. Whether it's bilious or non-bilious really depends on the level of obstruction. Anything after obstruction happens after ampular vata, then you would think that it's bilious, because you've got bile duct bile secretion into the small bowel, and of course anything proximal to it would be non-bilious. So on X-ray, you can tell if there is depending on what bubbles you see. Is it a single, a double, or triple bubble? You can tell them whether is there some form of atresia. Gastric atresia, duodenum is a double or triple bubble is your general atresia. And of course, whether there's distal bowel gas or not, then maybe it's not atresia after all, because you think atresia is a complete occlusion of your bowel lumen. And of course, in lower GI, you have obstruction, you have failure to pass meconium because something's blocked. And often as you wait for 24, 48 hours after, and if there's a lower GI obstruction, you think there'll be multiple dilated gas-filled loops of bowel. So just an example of upper GI obstruction, where you can see just two or three really quite prominent bowel loops, gas-filled bowel loops, and you can think, is this some form of atresia? Would this be a general atresia? And of course, that's the other one. You just get a lot of gas-filled bowel loops, and you're thinking something that this is more of a lower GI obstruction. A little table of how we think about this. So the traditional surgical approach is that if you've got any form of atresia, so absolute obstruction with no distal bowel gas, so you follow the middle column. Let me bring my pen up. So in the middle column of abdominal radiographs, esophageal atresia, which we'll carry on later, talk about it later, duodenal atresia, double bowel sign, then you go straight to surgery. And anything where it doesn't fall in these categories, then you can use your fluoroscopic study to help you differentiate. So if you've got upper GI obstruction or bilious vomiting, that's common cause for why you need to do upper GI study. So you do it, and from there you can differentiate between these three differentials. And pancreas is quite a rare thing. In fact, I don't think I've seen one. You can do it on ultrasound or fluoroscopic study, but I think the more commonly diagnosis would be volvulus or web or stenosis. I don't think I've really seen an annular pancreas in my training so far, or in my career so far. And for lower GI obstruction, you are looking for doing a fluoroscopic enema, so the bottom up. And what you're looking for is small bowel or colon atresia, as evidenced by some form of microcolon distally, Hirschsprung's disease, so, reverse of your rectal sigmoid junction, which we will see later. And of course, whether you are thinking, is this something more like a Meconium plug syndrome or Meconium ileus, which can be managed conservatively. Okay, and of course, if you think, okay, what if we don't know anything and you need to do both upper and lower GI, then you want to think, which one should I do first? And often you want to do the upper GI study first, because the upper GI will give you, you can use the contrast to look for your DJ flexure, because if not, if you do your enema, it's going to give a lot of contrast and it can often obscure your upper GI views. Okay.
Sam, excuse me, Sam.
Yeah.
Can you please, there is stop, please. There is a line there which is get rid of that.
Nasogastric tube, which is seen coursing along the midline with its tip projected over the anatomic location of the body of the stomach. There are some multiple external wires indicating the patient is acutely unwell. I see that there is two bubbles are seen within the stomach, suggestive of the double bubble sign could represent a duodenal atresia or an annular pancreas. I would like to suggest for a further upper GI study to diagnose the same.
Okay, I'll tell you feedback rate later. Next one. So you've got two different cases here. Actually, no, same case, different times.
The second, this is the nasogastric tube is appropriately positioned. There is a single bubble of the stomach. And in the second image, at a later time, there is
yeah. So at the later time, yeah.
Of, there's no other bowel loops are not seen. The small bowel loops.
Yeah.
Stomach is gas filled.
Okay. So between the first and the second, how has it changed?
The nasogastric tube has been removed, and there is only a fill up of the stomach with air. Rest of the bowel loops are not.
So in the first one, you say there's one single bubble. In the second one, do you think there's one or is it two?
Second one, yeah, there are two bubbles.
Yeah. Okay. So and then next one.
This is a frontal radiograph of the abdomen, which is showing there are two bubbles in this. So this could represent a double bubble, as in duodenal atresia or annular pancreas.
Okay. Do you see anything else on top other than the double bubble that you might not have seen previously on the previous cases?
There is a tube projecting over the midline in the upper part. So this could be a nasogastric tube, which is could be esophageal atresia.
Okay. Okay. Well, okay. So good attempt. Well done. So essentially what I'm going to show you the difference here is that if we go back, I mean, I'll show you this again, but we'll just go back and forth. So well done. The first one's a classic double bubble. As I said earlier, if it's a classic double bubble, jejunal atresia, it's complete duodenal atresia, not jejunal. It's something that the surgeons wouldn't need you to do an upper GI contrast on, because there is nothing else to, there's no further gas distally, and essentially what they need to do is to go in and operate. So they're quite happy with this. You don't have to wake up in the night to do an upper GI for this. The second one just hones in the point of, remember I said bowel gas takes time to progress from when at different times. So if I'm not wrong, after 1 hour you get from stomach to small bowel. So essentially this was done when baby was just born. I didn't tell you the time, so you need to wait a few hours in order to tell whether there is what kind of presentation pattern it's going to be. Okay, so that's the second point to make. And again, because there's no distal bowel gas, that's it. You don't need to do anything else. Surgeons will take over. And now the third case is the one that you, or rather as pediatric radiologists, you probably want to just sit up a little bit more and say, hey, we are not going to leave this alone. And that's because there is a presence of distal gas, which means that things have gone through or things are going through, but now patients are unwell. Why is it so? Is it because they have started to have a volvulus or a malrotation and causing something that's more sinister? Okay, so which is why this is one that you want to keep in your head and say, so there's double bubble, yes, but there is also presence of distal gas, and you just want to ensure that you want to do an upper GI contrast study, especially the surgeons are worried, to exclude other further distal obstruction from this distal to, of course, this double bubble sign. Okay, So the first few cases, so we've talked about duodenal atresia, so you can present antenatally with bilious or non-bilious vomiting, so depending on where your obstruction is. And atresia, you have a complete double bubble sign because it's a complete atresia, so there's no luminal opening at all. And you've got stenosis with something a bit incomplete. These, to tell the difference, the surgeons will need to go in to have a look. But it's easy. Well, it's easier for us because it's whether there is distal bowel gas present. And of course, with stenosis, what you can get is that you've got hyperperistaltic bowel seen on fluoro prior to the obstruction, and then distally it takes some time for contrast to go through, and distally you can see bowel gas. Duodenal webs are rare, but we do see them from time to time. So what's atresia associated with? A lot of syndromic sting, like trisomy 21. Again, you can get annular pancreas. And of course, if you're thinking syndromes, you need to think of VACTERL. And one of the surgical consultants used to tell me, if you have one atresia, they need to look out for other atresias. So they might always ask you to come back and say, can we do another fluoro or study from the bottom, from an enema, just to exclude other forms of atresia. As I said earlier, distal gas helps to differentiate on your initial radiograph on the urgency of doing this upper GI contrast study. And as I said earlier, essentially what we're looking for is that hyperperistaltic dilated bowel segment prior to the obstruction. Okay. Small thing is that if you've got, very rarely, even if you've got duodenal atresia, and this is really rare, you can also have distal bowel gas, just because they have an anomalous biliary tree that has allowed gas to enter from some way or another. And you can also, true duodenal atresia can sometimes have distal bowel gas, but we are not, those are a bit more complex. So it's just to recognize that for the purpose of the exam, if it's a duodenal atresia, there shouldn't be any distal bowel gas, and it's not something that you need to do an upper GI study for. Okay. So it's just to show you what I've said earlier. And then this is an example of a duodenal web. This, as I said, there's a little bit of distal bowel gas, so which means that it's not a complete obstruction. And this is how a duodenal web looks like, and it's an incomplete narrowing of duodenum with a windsock expansion, because it looks like one of the ones you see at airports. And then you've got a very central pinhole aperture, and then sometimes you can see a jet of contrast coming through. Okay. Right. That is okay. So case 3. So what does this X-ray show? Candidate?
This is frontal radiograph of the abdomen. There is umbilical cord clamp. It's a newborn baby. There is a triple bubble sign suggestive of jejunal atresia.
Yeah, so that's right. So the last form of atresia that we haven't talked about. So you got a single, the gastric, the double is a duodenal, and the third is your general atresia. And often these atresias are presumed to be due to some sort of vascular insult, probably in utero issues. And as I said, there are different types of atresia. Essentially, you've got in histopathologically or surgically, they can look and they say whether it's membranous, fibrous, complete or not. But from the radiology point of view, if you use the word atresia, it's a complete luminal obstruction. Okay, so just a summary, as I said, again, it's just a lot of repetition, double or triple bubble. No distal gas is your classic atresia, and of course, if you've got distal, you need to do upper GI fluoroscopy. Okay, right, case 4.
This is an upper GI series showing that the contrast is passing through the stomach, duodenum, and the DJ junction is appearing at L2. It is not crossing towards the left side. So this could be a malrotation with a volvulus.
Okay. Are you seeing any evidence of volvulus here?
Not too sure. I think the second image. Probably.
Which is the second image? This one? The one on the right? The one on the left?
The one on the right.
Okay. So, okay. Right. So this is a malrotation, but there's no volvulus. Okay. I'll show you examples of volvulus later. Okay. And then we'll just talk about it. So this, I might have given the answer away. So what do you think of this?
Okay, this is a volvulus with
yeah.
This is a malrotation with a volvulus.
Yeah, and why you say it's volvulus, because you can see this corkscrew pattern of the bowel loops on the lateral, on the sagittal film, less well seen on the AP, but definitely what you can see is that you've got a contrast going into your first part, second part, third part. You don't really see where the fourth part is, and then you see these contrasts going further down. And I think from an experience point of view, it's really hard to get. Often when you see malrotation, you have to purposefully wait or give extra pressure when you're air into the syringe or the NG tube just to push contrast through to demonstrate that corkscrew appearance. So it's something that you don't always see, but it's when you see malrotation, you want to be mindful that malrotation predisposes to volvulus. Okay, so what's a malrotation? So malrotation is your failure of your gut to complete the rotation. And of course, when you say malrotation, it's your abnormally located duodenum or DJ flexure. So what's normal? So your normal, you've got your midgut goes outside of the abdominal cavity to allow it to grow. It then turns 90 degrees anti-clockwise along the SMA axis and giving it to all your ileums on your right-hand side and all your colons on the left-hand side, as in this picture here. And so when that happens, that is a non-rotation. And if it continues, then it goes another further 180 degrees. Now your cecums in the right-hand side, your ileums in the left-hand side, so it's kind of switch positions, and then it retracts back into the abdominal cavity. So we use upper GI contrast studies to assess the DJ flexure. And this just shows you a pictorial representation and what we see fluoroscopically. So on your normal upper GI study, you take two views. First, you've got your AP or your supine view, then your right lateral, and then you back again on your supine. So what you want to see on your lateral view is that it goes, your D2 and 3 follows a retroperitoneal course, goes down, and then up and anteriorly towards the stomach. Okay, because your DJ flexure is...
Sam.
Yeah.
Are you pointing to something? Because we cannot see your pointer. Are you pointing or you're not pointing?
I was using a pen to point, but I guess you can't see it.
Yeah, now...
Is this better?
Yeah, this is better.
Okay. Yeah.
Now I can see it. Please continue.
Fine. So as saying on your on the middle picture, so on the lateral view, your contrast goes retroperitoneally, okay? Then it goes up and anteriorly, because your DJ flexure is really more an anterior structure. And on the AP view, what you're looking at is your D3 crossing the midline, and your DJ flexure is on the left of the vertebral body at the same level of the pylorus. Okay. So these examples of a normal upper GI contrast study, look how nicely on the lateral views or sagittal views that it goes posteriorly backwards, retroperitoneal position, up and anteriorly, and then on all the supine views, you've got contrast going across the spine to the left, up in the level of your pylorus. The important thing to note here is that as some of these have shown, so particularly the last two pictures, even the supine, and you want to make sure that your DJ flexion is right position, you have to look at have the patient quite well centered, seeing both costophrenetic angles, okay? Because you can very easily make this picture look what it is if you rotate the baby as well. In a malrotation, as in a true malrotation, you can always make something look normal when it's abnormal. Okay, so just be mindful that you always have your costophrenetic angles in a well-centered child. Okay, so malrotation is a risk factor for volvulus, as you said earlier, and the reason why here is that when you've got non-rotation, you've got this mesentery. So in a normal rotated child, this mesentery is really long, so it doesn't predispose you to volvulus. But when it's very short, it does. That will be a focus where things can twist, causing the volvulus. And at the same time, you have these lead bends as well, and these lead bends can cause things like internal herniation. It can cause GI obstruction, or periduodenal hernias. Okay, so. And that happens when you have either a series of non-rotation or malrotation. And volvulus is a risk factor of these rotational abnormalities. As said earlier, commonly present with bilious vomiting, and you can have it associated with other abnormalities as listed here. If it is a malrotated patient, even if you don't demonstrate volvulus, you want to let the surgeons know that this child has a malrotation, and even if you can't demonstrate a volvulus, what you do is that the surgeons will then either watch and wait or take them to surgery to explore and divide any leads bends or the mesentery and then reposition the bowel. So the other thing here is that increasingly in America, in a lot of papers, they say even if you can't see the volvulus on fluoroscopic study, you're going to try to use ultrasound. And in ultrasound, what you're looking for is a SMA-SMV relationship, although bearing in mind 30% can be abnormal, but they're still within normal limits. And you're looking for that whirlpool sign, especially if you've got volvulus. So if your SMA-SMV relationship is abnormal, you're thinking, is there a malrotation? But not all malrotations give you volvulus. Okay, they can is a risk factor, but they don't. But if you have volvulus, you're looking on ultrasound for that whirlpool sign, as what you see also in CT for volvulus. Some people say you can use ultrasound to look for a D3 position. I'm not a GI radiologist. I find it really hard, but I know of people who can. And of course, we're looking for other causes of why they are poorly. Okay, dilated bowel loops. Is there some sort of atresia and things you're looking for on ultrasound? So your normal SMA-SMV axis, your SMV should be between the 9 to 12 o'clock position relative to your SMA. Okay. And if it's abnormal, you can see if your SMA is here, your SMV normally should be here, but it's on the other side. So that's reversal. And in volvulus, what you're looking for is this swirling of the mesenteric vessels. That's why I said to predict, giving you a highly suspicious of volvulus. So these are some cases, just to show further case of malrotation, but without volvulus. So you can see that your DJ flexion does go down, but doesn't really go back up. And you don't, some people say you can just use the lateral view to diagnose where the position of DJ flexure, but I think traditionally we often use 2. And so you can see that on this side, your DJ flexion doesn't quite go high enough. And even you put more contrast, you wait a little bit and still it doesn't. So your DJ flexion is always on the right. But yes, some people may argue, but it's not a perfect fluoroscopic study. This one probably is, but not really this one, just because you, as I said earlier, patient's quite rotated. You can't really see your costophrenic angles, and you can see that the ribs on this side is quite shorter, much shorter than on this side, showing that the baby is rotated anyways. Okay, so volvulus, showing you this corkscrew pattern on the lateral view. And you can see it nicely on the lateral and also on the AP view. Okay, this swirling, as you can think about it on your ultrasound, you're going to see something like this. Okay, so that's probably your SMA, and that's the SMV or mesenteric vessels, just giving you this nice swirly pattern. Okay, so when we talk about this, we also need to talk about other rotational abnormalities. So as I said, one of the ones where you've done the 90 degrees anti-clockwise, but you haven't done the full rotation of 180, you get non-rotation. So all your small bowels on your right and your colons on the left. So an example of that, so your cecum is not really on your right iliac fossa, but kind of in the midline. And then since we've talked about the normal, we've talked about abnormal, we now talk about some normal variants. Okay, so we've got your duodenum redundum and your duodenum inversum. And this is also called a wandering duodenum. It was described by Feldman in 1934. If anyone's interested, there's a radiographics article. And essentially, you have what we call elongation of the superior portion of your duodenum. So you can see that this one, this bit's usually the first part of your duodenum, first to second, is very redundant. You just wait a while and like, where does it go? And then finally it does a little loop before it goes up to your normal position. Some of you may wonder, is this volvulus? Is what's going on? As I said, we need 2 views. You don't know which part when this patient was taking this fluoroscopy is done. Is that enough? Because it's a dynamic study, you do have to wait and watch and look at all the contrast. So still shots are often not the best way of demonstrating, and you really need to be there to watch it. But after seeing that, you can see it's nicely that the DJ flexion is the right position after a bit of a wobble here within the loop. And later on in the study, you really don't see any evidence of volvulus, nice filling of the distal bowel loops. Okay. The other one is a duodenal inversum. So what happens is your second part of the duodenum, second part of the duodenum goes down, goes up, and really kind of hangs on the right-hand side before crossing the midline above the pancreas. Okay, so it's another one called duodenal inversum. I think when you come to these kind of duodenal variants, it's always hard, and I certainly know, it can be miscalled, but I'm showing you some of the more traditional ones, or the ones that are quite commonly described. So at least you are aware that duodenal variants also exist. Okay, so then the other mimics of malrotation, I thought this was quite an interesting one. So one of our patients, so this boy had a chronic was chronically PEG fed. Ever since the age of 1, he always had a tube in, a PEG tube in, and this was one that was inserted. You can see that your PEG tube, so percutaneous tube, is in the stomach. It comes down, and then pylorus probably here, down the duodenum D2, so D1, D2, D3, and D4, and in the jejunum. So this is a nice C shape. It's suspected of a normal DJ flexure position. That's on the 7th, and then on the 8th, the surgeons wanted another repeat just to check, or I can't remember what happened to him, so they just did another one. And there's this odd appearance. Why has this tube now in the region of the right iliac fossa? Why is it not in the left upper quadrant? What's going on? So some contrast was put on the same day. You can see that it nicely fills your jejunal loops. So question here is this what's wrong? And so in patients with chronic PEG fed, and if they're since a lot younger, the weight of the tube is actually quite heavy, and with long chronic tube insertion, what happens is that you have this ligament of threads, isn't it, that holds your DJ flexion in place, and the weight of it causes it to distend or to become lax and extend. And so essentially what you have is a very lax ligament. And so you just have to be careful. And what to do is that you can retract it slowly. You can do an upper GI contrast study. In this case, what happened was that the surgeons were like, we're just going to refit this tube, which they did. So unfortunately, there's also another one. So this one also looks very similar, but there are things to look out for, which is this is a malpositioned tube. So very, very similar. So which is why the history is very important, and also constant discussion with the surgeons. So this patient actually has a pneumoperitoneum. And this is one where the tube has gone in and actually perforated through the small bowel. Okay, and the reason of that is because you see all these free air. So even though pictures can look very similar, you need to correlate the clinical history. And this is a neonate who had just had this inserted, no prior history of long-term tube insertions. Okay, so other things you think about, you can also have a very distended, also let's say something like a big renal mass that's displacing your DJ flexure, which I haven't shown here, of course. And if you've got scoliosis, your DJ flexure position can also change. So remember, even though on fluoroscopic study, the DJ flexure looks malpositioned, there can be other reasons to cause it. And ultrasound is often quite helpful to just exclude other causes for your for disappearance. So in my practice, what I do, I often do an upper GI contrast study. If it's abnormal, it's showing a malrotation, I often just put an ultrasound probe in just to have a look as well. Okay, but everyone's a bit different, so yeah. Okay, we're going to lower GI. Any questions you can write in the chat, and I will answer them during the break. So candidate 1 or 2, I don't know who's next.
Hi, it's me.
Hiya.
So this is candidate 2, Sam. Over to you.
Okay. Yeah.
Okay. So this looks like a lower GI contrast study, and I think the contrast is pacifying the lower bowel quite well. However, it doesn't reach the small bowel loops.
Okay.
I feel like there might be a few filling defects within the large bowel, and I'm worried that the patient might have Meconium plug syndrome. So I would review the patient's history and see if the clinicians were worried about that, and if they were, this is possibly the cause for the patient's symptoms. And I guess the contrast study itself can be therapeutic and can help resolve the obstruction.
Yeah, Good, it is. Okay, so next one.
Okay, so this is again lower GI contrast study, and I think there is a change in caliber of the large bowel, and the descending colon looks much smaller in caliber compared to the rectum, which appears quite distended. I suspect these findings are secondary to an underlying Hirschsprung's disease.
Okay.
Yeah, and I get, and the diagnosis could be made by a biopsy below the level of the transition point.
Okay, so this one was also. Can someone just mute me? Okay, yeah, okay, right. So this is also, so the case 1 and 2 is the same. They are features of Meconium plug syndrome, okay, or small left colon syndrome. And we'll talk about that. And then case 3, what do you think?
Case 3, again, a lower GI contrast study, and I think I still see a few filling defects within the lower descending colon, and then there is a short, there is a microcolon again, and the small bowel loops are not opacified with contrast.
Yep. So this is also, so case 1, 2, and 3 is demonstrating different kids with a small left colon or Meconium plug syndrome.
Mm-hmm.
And so thank you for that. So it's really a functional obstruction rather than a mechanical. No one really knows what it is. Some people say it's an immaturity of ganglionic cells. And of course, patients with diabetic mothers, or if they use some sort of antenatal magnesium self-exposure, they are increase of getting this. It's very transient and often affects the left colon, okay, with meconium plugging the bowel distal to this segment. And so it's, I mean, there's 2 names to it. One is Meconium plug syndrome, another one is neonatal small left colon syndrome. And what normally happens is that you see a small left colon. So as a microcolon, just remember it's lesser than the width of the vertebral body of the patient. And then with a transition point, you have filling defects and you have a normal spectral-sigmoid ratio. And that's because if it's abnormal, you're thinking of Hirschsprung's disease. And as what candidate 2 had mentioned, in a contrast enema can be quite therapeutic to help with just a passage of meconium, just because it's a water-soluble contrast and you've got the osmotic effects of it. Okay, so it usually resolves with time, because it's transient, and so contrast enema would help, and also rectal stimulation. Okay, next case.
Okay, next case. I'm looking at the pre-contrast image first, and I think there is multiple dilated loops of bowel, and the lower images are a lower GI contrast study, and I think the bowel looks small in caliber overall, but contrast is opacifying the entirety of the colon, and there is contrast within the terminal ileum as well. So I think this is a microcolon, but with filling defects in the terminal ileum. So I'm worried about like a meconium ileus, and I would wonder if the patient has any predisposition to or any history of cystic fibrosis.
Yeah, that's good. So that's good. So essentially meconium ileus. So just remember, meconium plug and ileus is very different. So meconium plug, often you're thinking is a plug of meconium causing microcolon on the left side, and meconium ileus is where you have entire microcolon of the whole colon itself, and it's because you've got impacted meconium in the terminal ileum. Okay, so what you need to do during fluoroscopic study, what we need to do is to make sure that we get contrast as much as can, refluxing back into the small bowel, into ileum, so that we can look for these filling defects. The meconium in meconium ileus is normally abnormal because you're thinking of something where you've got a secretion, abnormal problem with secretion, so things like cystic fibrosis, some sort of pancreatic dysfunction. Of course, you can also see this with things like pancreatic atresia or stenosis of the pancreatic duct. This could be one of the earliest manifestation of cystic fibrosis, and often when you see that, you want the clinicians to test for a sweat test just to check that they don't have it. So about 20% of patients with cystic fibrosis can present with Meconium ileus at birth. So as I said earlier, you get a full microcolon, so the whole colon is small. If you've got these multiple filling defects in terminal ileum, of course, there are some complications to that. You can get segmental volvulus, you can get atresias, you can get necrosis. But what the other thing that you think of is often perforation, because if you've got a hold up of meconium, you can perforate. That can be done either antenatally or sometimes when you're doing the contrast enema as well. Okay. So meconium pseudocyst, it's a complication that can happen with meconium peritonitis. And so meconium peritonitis is when you've got perforation, usually antenatally, and then you've got meconium within your abdominal cavity. And what happens is that when these extruded meconium comes out, it can be walled off, and you often see these pseudocysts. And when you ultrasound it, because they either clinicians may be able to feel it, so you do an ultrasound, and this is what it shows. Of course, the other differentials to think this is whether it is a duplication cyst, but what you want to make sure is that there's no laminar or trilaminar appearance that you see in a duplication cyst versus a meconium pseudocyst. And you're also looking for things like other things that could support your differentials or your diagnosis, such as calcification, because we know that when meconium is extruded, you can get calcification as well. Okay. So another case, so that is antenatal perforation, and you can see this lucency over the liver, showing this pneumoperitoneum, and also calcification, intra-abdominal calcifications. And remember, these ones, they stay. So in adults, when you see calcification in the abdomen, sometimes you got to think back, is this something that happened when the patient was a lot younger? Okay, so as I mentioned earlier, you can get meconium perforation even when you're doing the contrast study. So whether is it an existing defect that you're just leaking contrast as you're putting it through, or is it something that you've created? Okay. It's not uncommon to have meconium perforation when you're doing a contrast enema. Rare, but not uncommon. So other examples to show that, and what you can see here, you've got contrast just extending all the way and just coating the surface of the liver, and also within the mesentery. Okay, next case.
Okay, so the first picture is abdominal X-ray, which shows the baby's got a nasogastric tube in situ, and there's multiple dilated loops of bowel. I'm looking at the lower GI study now, and I think there's a narrow caliber of the large bowel overall.
Okay.
And there is the rectosigmoid looks a bit distended. I'm not sure if this is. I'm looking for like a sawtooth pattern to see if it's Hirschsprungs, but I'm not sure. Don't see any filling defects within the large bowel, and I don't see any contrast within the small bowel loops. Could this be an ileal atresia?
Yeah, so you're right. So this is one of ileoatresia, and it's often very hard to tell if this is a ileoatresia or if it's a meconium ileus, because the main difference is that one, you can see the meconium plug, the meconium in the terminal ileum, and one you cannot. But as I said, it really depends on whether you can reflux contrast back in the terminal ileum. If you've got your competent ileocecal valve, then it can be very difficult. And this is one of ileoatresia. And often you can only make this distinction when the surgeons have gone in surgically. So this is one, and you can see this diffuse microcolon of the whole total colonic microcolon, and it is a lot smaller in caliber than the width of the vertebral body. Okay. So atresias, I think a lot of people find it, or rather, it's quite hard to determine what's causing it, but often the literature says it's caused by a vascular or ischemic event. As I said earlier, it's the most accepted kind of theory, and it's hard to tell if it's truly ileal or jejunal because we don't get contrast all the way back up. And what literature says that is there equal involvement between the jejunum and ileum, and in fact 7% of it involves both. As I said very earlier on, if you've got one from atresia, you want to think of whether there's further areas down in the colon with atresia. And similar to Meconium ileus, you've also at risk of perforation and Meconium peritonitis with similar signs as you seen earlier. We've got peritoneal calcifications and get pseudocysts. Okay, so the good thing here is that when you do an ultrasound, or sometimes when you do an ultrasound, you can see a dilated ileal loop, which can help you with the differentials, or you can just get multiple distended fluid-filled bowel loops. And as I said earlier, it can be multifocal. You can have antenatal perforation. Okay, next case.
Okay, again, the pre-contrast showing dilated loops of bowel and the lower GI contrast study. I can see that the contrast is within the descending colon and the rectum, but I'm not sure I'm not sure where it goes after that. I don't think it's pacifying the ascending colon, and I don't see any contrast within the small bowel. I'm wondering if this might be like a colonic atresia.
Okay, so I think what this image shows is one of the ones that you mentioned earlier is Hirschsprung's disease. Okay. And I thought I will stop and mention that reason why. So you are in the Hirschsprung's disease, the main thing you're looking for is your rectal sigmoid junction. So how do I tell what's rectal and sigmoid? I often use essentially your sacrum. So if you are looking at this, that's probably the area of your sacrum. So that's your rectum, and whatever that it's interior to it would be, or above it would be your sigmoid colon. So it's important to do this without a balloon. And essentially what you're looking for is distendability of the rectum. Because if you put a balloon there, you're artificially distending the rectum. And of course, at the same time, you're looking for any sawtooth pattern or any spasm of the rectum. And what you can see, so your rectum is your reservoir. Your rectum should always be bigger than your sigmoid colon. And I think in these pictures, what you can see is that your rectum doesn't distend, and your sigmoid is the one that's distending. So there's reversal of your rectal sigmoid ratio, just because your rectum should be the bigger reservoir as compared to your sigmoid. Okay, and what you have here is also the spasms, which would make you highly suspicious of Hirschsprung's disease. So what you have in Hirschsprung's disease, you've got it's a congenital anomaly of your nervous system. So you've got no ganglionic cells, so you've got no peristalsis within that segment, and often because it's very small and very collapsed. It always starts anally, so starts from the distal end and going upwards. And so you can have very short segments, mid segments, and to very long segments such as total colonic Hirschsprungs. And the good thing here is that your contrast study cannot say this is definitely yes or definitely you can't say this is definitely Hirschsprung's disease, but what I can say is that you can suggest that it is because of the reversal of the ratio and also of the evidence of the spasms. And when you tell the surgeons that, what they'll do next, they'll do a rectal biopsy, which is the gold standard test. Rectal biopsy, so any biopsies, any risk for that is perforation. And I think so far I've only seen one, so it's a fairly safe procedure. And because I said the part of the bowel that's affected by Hirschsprung's, you don't have that neuroenteric cells, so you've got very collapsed bowel, and the proximal to that is very dilated. So what you have is a very sharp transition zone on the lower GI contrast study, and of course, this can be associated with Down syndrome. Okay, and it doesn't have to happen in neonates. Some people have a delayed diagnosis of Hirschsprung's, and often in an older child, what you have is constipation since birth, and you get enterocolitis because of the organisms that are being stagnant within bowel. In a neonate, things that you would happen that would present would be abdominal distension, failure to pass meconium. So similar to the other causes of lower GI obstruction. Okay. I know I've been quite fast here, so this might be a short session, but certainly if there are any questions, I can answer them during the break or in the next 10 minutes. So it's just a quick summary. We've gone through the upper GI causes of neonatal obstruction, so the upper GI causes. You've got X-ray, so your single, double, or triple bubble, different forms of atresia, your gastric, duodenal, or jejunal atresia, with no distal bowel gas. And of course, if there's distal bowel gas, you're thinking of something like a web, a stenosis, or is it a malrotation with volvulus? And that's when you need to do your upper GI contrast study. And lower GI study lower GI causes of obstruction, what you're looking for is your multiple dilated loops of bowel, failure to pass meconium after 24-48 hours, and often because of that, you don't see any gas in the rectum because it's some sort of proximal obstruction. You need to do a contrast enema. You put your catheter into your rectum, and what you're looking for first is that to look at the rectal sigmoid ratio, and then you continue. Once you've assessed it, you can then blow up the balloon and you continue to fill the colon up, and you're looking for the assessment for whether it's a microcolon or not. Is there any meconium within this? And finally, if you fill the colon all the way with contrast, you're looking for the small bowel, to see you can reflux it into the ileum, and you're looking for any meconium within the ileum. And of course, this helps with your electro and AP views. So a summary, just to say, these are the causes, as we said earlier. And if there, let me just see if there's any questions. If they're not, we'll just go with the break first. Okay, so I've got some questions here. What is inversum? So as I said earlier, it's a duodenal variant. Where is it? Duodenal, it's a variant. There is a very nice, I can't remember who described it, but it's a radiographics paper back in probably the 1930s or 1940s, which says that instead of your small bowel going immediately forming that routine, that nice C shape, going past to third part, what happens is that your duodenum is almost like a slightly redundant, but it goes up and then towards the right, so superiorly and towards the right before going across to the vertebral, the spine, to the left side, to the DJ flexure. Okay, so that's the inversum. Reversed rectosigmoid. I asked about the large gas-filled structure in the right lower abdomen. Rectosigmoid. Is it a Hirschsprung slide? Hang on. This one? Right lower abdomen. Are you talking about these? Are these just bowel loops that I'm looking at? Because that's, for me, that looks like your sigmoid, your descending, your transverse, and that's your ascending colon. So that's probably your cecum, and that's small bowel loops interposed over each other. That could be cecum because it's the same region. Okay. Any images of colonic atresia? Nope, I'm sorry, I do not have any images of colonic atresia here. Slides on causes. Hour-wise pattern. Hang on. Okay, so that's the slide on causes. So please repeat ileoatresia. So ileoatresia is on fluoroscopy, you see very similar appearance in ileoatresia as Meconium ileus, where you get total colonic microcolon. The differences between one and the other is hard to tell unless you can see meconium within your terminal ileum. So you get filling defects of meconium in your terminal ileum, and you see that, you can say this could be ileoatresia. Okay, if you don't see that, you can only say there's total colonic microcolon, and the differentials would include Meconium ileus, ileoatresia. You can use ultrasound to help you. If you think you can focus, you can look for, of course, presence of fluid-filled bowel loops. You can follow and to see if there's a transition point. I personally find it very difficult, and often in that case, I think the surgeons will already take the patients to theatre to explore them. Okay. So you're reading the first two slides of your normal bowel gas pattern. So that would be on your radiology assistant website. I think everyone should be able to get to that. It essentially just shows you how progression of air happens normally. So at birth is in the stomach, 1 hour is your duodenum, 3 hours, and then following that, after 24 hours, it should be in a rectum. And whenever you're interpreting an abdominal x-ray of a neonate, particularly if it's the first ever x-ray, it's just important to just bring the clinicians if you are not sure, and if you don't see a normal bowel gas pattern, just to find out when this was taken. Okay, so the next question is, explain malrotation on the lateral view again. Okay, where is it? So malrotation, so essentially on the lateral view, what you see here is that your second and third part, it should go retroperitoneally, so it should go towards the spine, and then it should go up and anteriorly because your DJ flexure is anterior. If I'm not wrong, this is one that was, do you have a paper by Alan Daneman from Toronto, Daneman, and he describes this. Okay. How to differentiate meconium plug from meconium ileus. So meconium plug is essentially plugs within the left side of the colon. That's how I think about it. And you should only have classic, you should have a left-sided microcolon. And that's how I think of it. If it's a meconium ileus, it's the whole colon that is that's microcolon. Not sure about this hourwise pattern or something that I was telling. Non-rotation. So non-rotation essentially, so I don't know one of the questions, but I don't know why you're referring to this hourwise pattern. But non-rotation essentially when your abdomen or your bowel structures don't complete your full rotation to 270 degrees. You've only done the first 90 degrees anti-clockwise, and essentially you have it where all your small bowels on your right hand side and all your large bowels on the other side. But all you need to make sure is that this is actually in a virgin abdomen and not because the surgeons have gone in and to fix the bowel because they have dealt with the malrotation and now they are just putting things one side to the other, okay, because they don't fix it back as they would think in a normal anatomical position. Duodenum redundant, essentially it's where you've got excess, or rather a redundant duodenal loop in the first superior part of your duodenum. So you're thinking the first part, or second part. So they talk about an elongation of the duodenal cap. And on your upper GI contrast study, what you see is that you don't see your classic shape of your D1. And so you just get a little bit more wandering. So you get a bit more duodenal loops in that region before it finally goes across and the spine into your normal expected position of your DJ flexure. Do non-rotation and malrotation look the same on the upper GI study? No, it's a good question, but I don't think it should. It's a good question. I never thought about that, but I think I had a picture to show it. So non-rotation, to be fair, I've never been asked the question whether non-rotation, malrotation looks the same. But if it's non-rotated, unless you continue the study further on, then I guess you can tell because you need to wait till your contrast goes into your colon is what I think. But I would say if it's non-rotated, I'll still say it's malrotated just because it's essentially, I think of it as the bowel has not rotated properly, and it's something that I will inform the surgeons. Although literature says that it's rarer to get, it is a risk, but it's rarer to get a volvulus in a complete pure non-rotation. Okay. Duodenal web versus duodenal stenosis, how to differ. I think personally that's hard. Certainly in experience-wise, there's a few duodenal webs that we called, which turned out to be duodenal stenosis. To be fair, what you see before that, what you're going to see is a hyperperistaltic bowel or duodenum before, with very little contrast coming through or very delayed passage of contrast. If you tell the surgeons that there is some sort of a hold up of contrast at the duodenum where there's a transition point, I think that's good enough. They can go in intraoperatively to help out with it. But I mean, I would think your duodenal web, you often give that classic windsock appearance. But I know we've had one case where we thought it was, but it turned out to be just a stenosis. They didn't think it was a web. And well, personally, I don't think to me the difference is more of something that's macroscopic than radiological. Meconium complications. So meconium complications, you get calcification within intraperitoneal calcifications. You can get pseudocysts. What else can you get? I think that's the main ones that I can think of. Sorry, going back. Yeah, volvulus. I guess maybe you've got adhesions. You can create volvuluses. That's why I think atresia are so common that is it truly a complication of meconium ileus or of some sort of ileoatresia? It's debatable, but I would think of meconium complications mainly as perforation with peritoneal calcifications and pseudocysts. Please share. Okay, I think ileoatresia point slide. Ileoatresia. Okay. In suspected ileoatresia. So good question. So essentially, I had the same as a case of ileoatresia. So what I started off with, I think it was a bit tricksy, as in nobody really knew whether it was truly atresia or not. So what I started off with was an ultrasound first, because I think ultrasound gives you overall view of what to expect. So I did an ultrasound first, and an ultrasound, what I saw was very dilated bowel loops, lots of it. But I could also use ultrasound to look at your SMV relation, which helped me to preliminary, and I say preliminary, exclude malrotation. So after doing that, I went to do an upper GI contrast study, which showed that because SMV SMA axis was normal, so I thought malrotation is really less likely. So, but I did upper GI contrast AE study anyway, just to confirm, just to reassure myself, and that was normal. And then when we did that was excluded, and we did the lower GI contrast study, which then showed that it was microcolon. I couldn't get anything to reflux back into I couldn't see meconium plugs within the terminal ileum because I couldn't get things to reflux back anyway. So I said, there are these different shows. You could think of total colonic Hirschsprungs, but it didn't really look like it. And it was a very early presentation. And I said ileoatresia, but given the appearances in the ultrasound, I was worried more of ileoatresia in the child. And so they went in to operate, and they found ileoatresia and I think also jejunal atresia. So I did both, upper GI and lower GI. Duodenal web, I will show you that windsock appearance. I think it's more of where is it? So that's your classic windsock appearance, where you just have very distended, and sometimes you can see a little jet of contrast coming through where there's a little pinhole aperture. Okay. Which contrast is safe in neonates for suspected lower upper GI study? I use water-soluble contrast. I use the highest, 350, just so that I can see more. I think differentiate between meconium ileus, I think I've already told you, is whether you can reflux the thingy back, the contrast back into your terminal ileum, and whether you can see the presence of meconium within the terminal ileum. Okay. Right. I think that's all the questions.
I'll just add a quick question,
okay.
A quick point. Sorry.
Go ahead.
I'm doing the next session.
Yeah.
Just on the point of contrast. So generally in these lower upper GI contrast studies, we use water soluble, so Omnipaque 300 or whatever. I personally dilute for my lower GI studies.
Yes, right.
Just because they tend to present more acutely obstructed and you don't want to do as much fluid shifting potentially. Barium we don't tend to use just because A, if they have to go to surgery, it makes it more complicated for the surgeons, and B, the risk if you perforate, for example, whilst you're doing the study, then it can cause a peritonitis. So barium is best avoided.
Yep. Thanks, Toby. Yes, sorry. So I did lie. I use OmniPic for my upper GI studies, 350, but for my lower GI, I always use Duographin of 100, 150. So yes, it's diluted the form of iodinated contrast, water soluble. Yes. I mean, there are people who say that if you really struggle to see the DJ flexure in your, and you just want nicer pictures, but you know that it's a normal, it's not a malrotated study. After your water soluble contrast, you can give barium. But I mean, that's what people say when you hear people talk about it. But it's not. I mean, I don't do it. And I think Toby, like what she said, she probably doesn't. The name is OmniPig. I actually don't know what's duodenum rotundum. Toby, do you know what's duodenum rotundum? I've got a direct message. I have no idea what duodenum rotundum is.
I've not come across it, but I can do some reading in the break.
Yeah. Okay, so shall we have a break? I think this might be a short session, so I apologize. We may not reach 3 hours, but we're happy to answer any more questions at the end. Okay.
So candidate 3, once you're ready, you can start presenting this chest X-ray.
Yes, sir. This frontal radiograph of a child demonstrates there is a nasogastric tube seen in the upper part of the cervical esophagus, coiled upward. There is no passage of the nasogastric tube to the gastric bubble. I see also there is right intravenous right lines is going through the. This is through the gastrointestinal through the cava to the right atrium. This is the tubular structure on the right side of the spine. So I am dealing with the case of esophageal atresia.
Okay, and so there's an esophageal atresia. We can see that the tube is coiled in the esophagus. This is actually an ECG lead, like a heart monitoring lead. You can see down here. This is the sticker that they place on the chest, and then there's a similar lead on the left side of the chest wall. So no tubes. So apart from the esophageal atresia, is there anything else that you see?
Excuse me, Toby. What kind of you are using the pointer? Or
yeah. Can you see it?
Can you move it, because I cannot see it right now?
Can you see it now?
I can see it now.
Okay. So sorry, I was saying that this is the this is actually the sticker for an ECG lead here. So this is just an ECG lead rather than a vascular line. And then you can see there's a similar appearance on the left chest wall. And then this is the NG tube as described, coiled in the proximal esophagus in keeping with the esophageal atresia. What else about this radiograph? What's the other feature on this radiograph related to the esophageal atresia, candidate 3?
I see there is gas in the stomach bubbles, I see. So I'm going with tracheoesophageal fistula. Tracheoesophageal fistula. I think this is type C, with the proximal esophageal atresia and distal tracheoesophageal fistula. Okay.
So we don't tend to type on the chest radiograph, but by the fact we've got a proximal esophagus, that's where the NG is coiled. You can have a hazard as at the guess of the type. But yeah, you're completely right. The presence of gas in the stomach suggests that there's a fistula between the trachea and the distal esophagus. And then this is what's letting gas enter the stomach. So we'll just move on. So once you identify this on the chest radiograph, what else would you be looking for? So this is a different patient, which shows who also has esophageal atresia. So once you've made this diagnosis on your chest radiograph, what else are you going to assess on the radiograph?
Is this an infant babygram of immature infant? I didn't see is a ossification center, ossification of upper limb. I see there is two line as umbilical arterial caster, which is going through the chest. I think it's proper position above in the correct position, upper end.
What's the correct
also
position?
I see the venous caster, umbilical venous caster, which is going to the right, seen in the portal vein. I think it is due adjustment. It is proper position for here.
Okay. I don't see any just before you move on, candidate 3, what are the correct positions for the umbilical arterial catheter and the umbilical venous catheter for those who don't know in the audience?
The umbilical arterial catheter should be seen in the area. There is two positions, high level and the lower level. Okay. High level usually should be above D10. Yeah. Lower level should be just below number 3 vertebral level, to be away from renal arteries origin. Yeah. For umbilical venous catheter, I see it is should be adjusted to going to the junction of the inferior vena cava and the right atrium. To position. I see it directed to the right hepatic vein. Could be in the right portal vein branch.
Okay, that's correct. Okay, sorry, carry on assessing the radiograph.
For this radiograph, I don't see any gas bubble, any gas shadow in the abdomen. So, and also I see there is some linear tubular structure in the upper part of the esophagus. So I am going with this esophageal atresia, complete esophageal atresia without fistula.
Okay. So once you've made the diagnosis of esophageal atresia / tracheoesophageal fistula, there are other things that you're assessing for to make another diagnosis. What other things do you think you may be assessing the radiograph for?
I think was going with syndromatic syndrome. I think it's feces or VACTERL.
Okay. So what things can you assess as part of VACTERL on this radiograph?
And VACTERL, okay. I am check view for the vertebral anomaly.
Okay. So do you see a vertebral anomaly?
I search for here.
Okay.
I see vertebral limb. I see some could be some ornamental upper limb.
Mm-hmm.
The E for arterial. C for cardiac anomaly. I see could be for cardiac palpitation. T for tracheoesophageal fistula.
Mm-hmm.
Didn't remember the rest actually.
Okay, that's fine. I'll tell you about the rest. So in cases of tracheoesophageal fistula, we have to assess for something called VACTERL, which is a syndrome because esophageal atresia and tracheoesophageal fistula are associated with other anomalies, developmental anomalies. So on this radiograph, we can see a couple of them. So V is for vertebral body. So we're looking for any vertebral body anomalies such as hemivertebrae, fused vertebrae, and things like that. And you can see here at the sacrum that there's abnormality at S3, 4, and 5. So you've got what looks like S4 fused to S3 with only half the vertebral body present at S4. So it's probably a hemivertebrae that's fused to S3. We can also, anorectal malformations are associated, so that's the A in VACTERL, and that's often diagnosed clinically by the surgical team or the neonatal team when they do their baby check. And then C is for cardiac, so we can look to see if the heart appears enlarged, suggesting that it might be an underlying congenital abnormality. In this case, the heart is enlarged and the child actually ended up having tetralogy of Fallot as well, which in the UK we call this. If you have tetralogy of Fallot with a tracheoesophageal fistula, then we call it a double TOF, given the abbreviations. T is for tracheoesophageal fistula. So on this, we can see that there's no evidence of bowel gas in the abdomen or the stomach. There's no gas in the stomach, so there's no obvious fistula up here in this patient. O is for the esophageal atresia. It should be O, but it's an E because it's an American spelling, which is for esophageal atresia. So here we can see we've got a repulsor tube in the proximal esophagus in keeping with an esophageal atresia. R is for renal. So all these patients will have renal ultrasounds to assess for any renal abnormalities such as horseshoe kidneys, duplex kidneys, unilateral kidneys, single kidneys, etc., etc. And then L is for limb, and as correctly identified, you can see here that the patient is missing both their radial bones bilaterally, and the upper limb, the forearm appears shortened. So this child has limb abnormalities as well, which is what the L in VACTERL stands for. Can everyone hear me clearly, or is the sound not clear? I've got a message that someone can't hear me.
I can hear you very, very clearly. So the problem might be at the end of the person who has posted that. Please continue.
Okay, perfect. So there's lots of different types of esophageal atresias, as candidate 3 said. And basically, esophageal atresia is where you get a congenital occlusion of the proximal esophagus usually. And it's thought that it's due to faulty division of the foregut when it differentiates into the trachea and the esophagus, and it usually happens very early in the first trimester of gestation. From this faulty division, you can also then get a tracheoesophageal fistula, which is where you get a fistulous connection between the trachea and the distal part of the esophagus. And you can either get a single connection or you can get multiple connections, and we will see that evidence in the radiograph by gas within the stomach and the bowel. So if there isn't a fistula present, we don't see any gas. If there is a fistula present, we do see gas. And sometimes in the H-type esophageal atresia, you don't actually get a true atresia. All you have is a tracheoesophageal fistula. So that's a H-type fistula. and this is demonstrated on this image. And then the other thing to say is that the level of the fistula can be variable, but it's normally in the region of the carina, and how the gap between your atretic segment and your distal segment can also be variable, and it can be as high up in the neck, or it can be lower down in the mediastinum, for example. So sometimes the surgeons aren't able to do a primary anastomosis, and they have to use a conduit such as the stomach or the colon to anastomose and make a neoesophagus. So we've looked at the radiographic findings already, so I won't repeat them because I think I've said them many times already. So we've seen the cold enteric tubes. We can also sometimes see a thing called a repulgal tube. So that is a tube, I'll just show you the picture of it. So this is a repulgal tube here. Sorry, my pointer's gone. I'll just put it back on. This is your repulgal tube here. And basically it's a double lumen tube, and it goes into the proximal pouch and it drains the proximal pouch. So it shows, it helps because the patient will be swallowing their secretions all the time, so they need to have that drained. So that's what the repulgal tube does. It just drains that blind ending atretic segment, and it's either inserted orally or nasally into the patient esophagus. We don't do contrast studies to look for to diagnose esophageal atresia. It's normally done clinically, and sometimes it's even diagnosed antenatally, and it's done clinically on presentation. They can't pass the NG tube, and then they do a radiograph, and then that confirms the presence. But we do sometimes do contrast studies either to look for H-type fistulas, particularly in kids who get recurrent aspirations or have any difficulties with recurrent chest infections, and they think that they might have a hidden H-type fistula. Or we do it post-repair. So prior to them feeding the patient, we'll do a fluoroscopic study. Let's see if that shows up, to look to see if there's any evidence of a leak at the anastomotic site prior to them feeding the patient. So what we'll do then is we'll gently withdraw the in situ NG tube, which they leave post-operatively, and then we'll put some contrast down and see if there's any evidence of a leak. This image actually shows, I don't know why my pointer keeps coming off. So this image actually shows a fistula. So you can see here, this is your connection between your esophagus and your trachea, this little tiny bit of contrast that's extending between the two of them. And this is kind of the subtle things we're looking for trying to diagnose the H-type fistulas. With an esophageal atresia, the children will end up having esophageal dysmotility, so they'll have dysphagia. Some won't be able to swallow certain solids, and we'll sometimes do contrast studies just to assess the dysmotility and also look for things such as gastroesophageal reflux. And they can also develop strictures down the line at the site of the anastomosis. So we'll sometimes do a contrast study to diagnose this, and then they'll go on to have serial esophageal dilatations for the stricture. So VACTERL as...
Excuse me, Toby, there are some marks on the screen. Do you know how to stop annotations and how to clear annotations?
As far as I can see, I don't have any. Those...
So, are you on a Mac or on your...
I'm on my PC. How do I get rid of...
So if you know the zoom bar, there will be 3 dots there.
Yeah.
And if you hover on those 3 dots, there will be a drop up or drop down.
Yeah.
Stop annotations for all, and also in the same go clear annotations. We can see 2 lines there, red lines.
Stop annotate. I've got enable annotations for others.
Yeah, disable.
Yeah, so mine's disabled. I just disabled it.
Right, and another thing which you have to do is that you have to clear annotations. We can see 2 red lines on the screen.
Oh, that I don't know how to do. It's not giving me that option.
Okay, don't worry. Those of you, somebody must have accidentally done it. If you can undo it also. So in any case, let's continue.
Okay, give me 2 seconds. I've somehow turned subtitles on, so I want to turn them off. Okay. So VACTERL is a syndrome that's associated esophageal atresia and tracheoesophageal fistula are associated with, and it's often due to chromosomal anomalies. So frequently you see it in patients who have trisomy 18 or trisomy 21. And the associated anomalies are vast for each letter. So vertebral anomalies include hemivertebrae, like I said. They can have a scoliosis. They can have caudal regression, which is where the spinal the conus terminates high, and they would often get sacral anomalies with that. They can get rib anomalies. They can get tetralogy of Fallow and dextrocardia. They can get distal atresias in the small bowel. They can present with malrotation. So there's an endless list of different abnormalities that are associated with this. And basically what we're doing is we're trying to assess the patient to pick up as many of these as possible. And the initial radiograph is really crucial because it will pick up your vertebral anomalies. It can pick up your cardiac anomalies if you see an abnormal cardiac contour or renal or cardiac enlargement, and it can also pick up your limb anomalies. So you've really got to interrogate them. If they show you this case in an exam, you need to make sure that you're looking for all these other signs. I just wanted to mention about the UVC and the UAC. Neonatal chest radiographs tend to have multiple lines in situ. So as candidate 3 did there, you need to assess the lines and check the positions first before you then go on to present the pertinent findings in the chest or abdomen. So we're moving on to the next case. So candidate 3, do you want to have a go at this case? The findings are subtle, so if you don't get it, don't feel too bad.
Okay, yes. I was the frontal sonograph of immature infant. I see there is nasogastric tube passing to the gastric component region for stomach. I see multiple dilated bowel loop in the center of the abdomen. In the right hypochondrium, I see there is some mottling of bowel loop, pattern wall. I don't see any pneumoperitoneum. I don't see any intramural gases. So I am worried about small bowel obstruction, necrotizing enterocolitis for the patient.
Okay, perfect. And then we're going to move on. So this is a different patient who's presenting acutely unwell on the neonatal unit. So has a abdominal radiograph. What do you see here?
In this frontal radiograph, I see there is bowel dilatation, as well as I see there is intramural lucency in the wall of the bowel going with pneumatosis intestinalis. I see there is also gas going to the portal venous portal vein to the peripheral hepatic region. So this is a portal venous gas. So this is a case of necrotizing. I don't see any also pneumoperitoneum. So this is a case of necrotizing enterocolitis complicated by pneumointestinalis and the portal venous gas.
Perfect.
This is a surgical emergency.
Okay, perfect. I'm really sorry. You can hear beeping because I'm on call as well. So I'm trying to deal with some queries whilst I'm teaching, but you now have my attention again. But what you said exactly was correct. So I'm just going to go back to case 1 and say, so necrotizing enterocolitis can have very subtle findings on plain film. So I'm showing you a case of a subtle case and then a more florid case, which is the second case. So lines and tubes, you did again, which is, like I said, we have to look at those first because a misplaced line or tube can have its own complications. And then here we can see in that right side of the abdomen that there's some subtle bowel wall thickening, which is a non-specific sign for NEC, but necrotizing enterocolitis, but it's important to mention it. What I also look for is over a series of radiographs. If this child had 3 abdominal x-rays and they all looked like this over a period of the day or 2 days and the bowel gas pattern wasn't changing, that to me suggests that there's sluggish peristalsis, the bowel is not happy, and that also raises the possibility of necrotizing enterocolitis, even if I don't see all the other findings that I would typically see. So speaking of typical findings and things that demonstrate NEC, so we can see here, as candidate 3 described, you have linear branching lucencies over the liver shadow, and they reach to the capsule of the liver, so they reach all the way out to the periphery, and this is in keeping with portal venous gas. If this was biliary gas, it wouldn't reach all the way out to the periphery. It'd stay more central. So that's how you can differentiate between the two. If the patient had a UVC, umbilical venous catheter in, and I saw it was misplaced, like we saw in an earlier case where it was in the liver, and I saw portal venous gas, then I would more likely put that down to the misplaced UVC rather than necrotizing enterocolitis. But it's just an important point to have as a differential when you see portal venous gas. Is there a misplaced umbilical venous catheter? And then we can potentially see that there's possibly some areas of pneumatosis, although it's not super florid on this radiograph. And the other thing we're looking for is perforation, so any evidence of pneumoperitoneum, because these children are at risk of perforating these necrotizing enterocolitis. So what is necrotizing enterocolitis? Well, it's normally present in a very low birth weight or premature infants. And in the UK, we're now seeing babies going into the neonatal intensive care unit at 22, 23 weeks. So these patients are under a kilo and they're at very high risk of developing NEC. We do sometimes see it in term infants who have underlying other conditions that put them at risk of getting GI tract inflammation and ischemia. And what happens is they get inflammation of the bowel and they get translocation of bacteria into the bowel wall. And then they also, from the inflammation, it affects the blood supply and they can have ischemic changes, which we see as pneumatosis, so air within the bowel wall. Radiographs, like I said, it can be non-specific. So we can see anything from a gasless abdomen to distended bowel loops to a non-changing bowel gas pattern. So just because you don't see the classical diagnostic signs of pneumatosis, portal venous gas or pneumoperitoneum, you can never fully exclude NEC on an abdominal radiograph, and it's important that you make the clinicians aware of that. Also, there are some things that are suggestive of NEC which might raise the concern, particularly if you're reporting a radiograph of a premature infant, such as a thickened or dilated bowel loops. And like I said, a non-changing bowel gas pattern over a series of plain films always makes me raise the flag to say, could this be NEC? Most commonly, we see it changes in the right lower quadrant. I'm not exactly sure why, but that tends to be the most common site, but we can see it anywhere along the bowel. And it's normally managed conservatively. So they put the child on bowel rest, so they'll switch them to total parenteral nutrition, so IV feeding. They'll put an NG in for comfort if the bowel is distended to try and aspirate some of the gastric contents, and they'll start them on IV antibiotics to treat the infection / sepsis. If the child does not improve despite all the conservative treatment, or if they develop any signs of obstruction or perforation, then they'll tend to go for surgery. But you try and avoid surgery in these children because surgery comes with its own complications, and then they've got the potential for generating adhesions and so on and so forth down the line, which will lead to bowel obstruction. So we can do ultrasound to look for NEC. In the UK, we tend to use it as an adjunct rather than the first line imaging, which is still plain films in combination with the clinical history. But there are certain signs that we can see on ultrasound like we see on the plain film. So first of all, we can see pneumatosis. So here we can see, so these are loops of bowel, and you can see air is echogenic on ultrasound. So we can see multiple echogenic foci around the wall of the bowel, which is in keeping with pneumatosis intestinalis. And here we've got another more florid example here. What we can also see is we can see a paucity of peristalsis. So what I tend to do is when I'm scanning these neonates, I put the probe on and I leave it there for a few seconds and just watch the bowel and see what the bowel does. Does it move? Is it sluggish? Or is it actively peristalsing? And if it's sluggish or aperistaltic, then I'll raise the potential that this could be related to NEC. We can also assess for bowel wall thickening. So I use about 2 millimeters as my standard for normal bowel wall thickness. So anything above that suggests that the bowel is, as I like to say, unhappy and thickened. And then we can also assess for vascularity. So we'll see a paucity of vascularity in the affected bowel loops and in the mesentery supplying the bowel. Other things we can look for are, portal venous gas. So if you put your probe over the liver. You'll see little echogenic bubbles floating through the portal venous system. And if you put a colour Doppler on, I don't have an image to show you, I don't think, but if you put a colour Doppler on, you'll actually see little artifact of spiking on your portal venous trace, and that's because of the air bubbles going through the vein and affecting the Doppler. We can also look for free intraperitoneal air, so I like to look along the liver capsule to see if I can see any echogenic foci, which is in keeping with free air. And we also can look for focal collections or echogenic ascites, so free fluid which looks dirty with multiple echoes, which suggests that there might be a perforation. So ultrasound can be used to further assess, but it's really done kind of as a to look for a child who's already on treatment to see if things are progressing rather than to make the initial diagnosis. So we're going to move on. I think it's still you, candidate 3. I'll do the questions at the end. So candidate 3, have a look at this X-ray.
Okay, this frontal chest radiograph of a mature child, mature infant. The first I see the nasogastric tube go to the stomach gas bubble, so it is normal position. Also, endotracheal tube C in proper position just above the carina. There is, I think this there is a central venous line, intervenous jugular line passing from the left internal jugular to the right side. The chest radiograph and other for me is this intervenous line. Okay, I think it's proper position also. I see there is central rounded lucency in the abdomen. So I am more about the Pneumoperitoneum.
Yeah.
For the vision.
Okay, so that's this case. And then do you want to do this case?
Okay, in this case, I see there's dilated nasogastric tube C in normal position. I see there is multiple dilated bowel loop with some in the right side of the abdomen and the pelvis, some mottling or bowel feces sign.
Yeah.
So I'm worried about bowel obstruction. Okay. I don't see any portal venous gas, any intramural gas, not clear for me.
Okay.
For this one. So I think this is bowel obstruction for the young age. It is necrotizing enterocolitis also. I don't see any other Pneumoperitoneum or something perforation.
Okay, and then this is the final one. So what
in the second one, I see there is marked free air in Pneumoperitoneum. I see there is a dilated bowel, small bowel loop with regular sign seen both sides. This is this tube.
Okay, so you've seen 2 with pneumoperitoneum and 1 that's NEC/bowel obstruction, but no pneumoperitoneum. So let's just go back through them. So all the lines and tubes are in the right place. So the central venous catheter tip, it's a bit low. It's at the right atrium. It should be at the cavoatrial junction, but I'll allow it. ET tube and NG tube are correctly sited. So as candidate 3 said, there is this rounded lucency over the visualized abdomen. So what this radiograph is basically showing you, so if you ever get presented it in an exam, is that initially you're like, it's a chest radiograph, I need to focus on the chest. But don't forget to look outside of the chest and to look at the periphery of the film, because the abnormality might actually be there. So this is actually a football sign, which is incompletely imaged because we don't have the whole abdomen on, but this is seen in pneumoperitoneum. Moving on to the next case. So here we can see the mottled lucencies, suggestive of NEC, and there is no portal venous gas, you're correct, and there's lots of dilated loops. But up here, you've got this weird lucency that's triangular in the upper abdomen. And this is where your pneumoperitoneum is. So the bowel does not make triangles. So if you see triangles of air in an abdominal radiograph, it's pneumoperitoneum until proven otherwise. And then you can do a lateral shoot through. So either turn the patient decubitus and image them that way, or shoot through the side of their abdomen, and you look to see air at the upper part of the abdomen, like Sam showed in one of her earlier cases. I'm just going to go back to this. So this here, if you follow my pointer, this lucency in the abdomen is abnormal. So this is the pneumoperitoneum. So it should normally, it's called a football sign. So it looks like a rounded ball of gas, basically, which is sitting at the top of the, underneath the anterior abdominal wall. So this is your abnormality here. So this is pneumoperitoneum. This triangle of gas here is your pneumoperitoneum. So you can also see that there's no bowel wall around this gas. Like, so you can see here, you can see bowel wall around and here, but there's nothing around this bit. So this tells you that this is pneumoperitoneum. And then finally on this case, this shows a continuous diaphragm sign. So if we look very closely at the diaphragm, it looks like you can see the entirety of the diaphragm, even across the midline, which we don't normally see. And that's because you've got air on both sides of the diaphragm. So you can see it in its full extent. So this is pneumoperitoneum. And then you've also got, as candidate 3 correctly said, you've also got wriggler signs. So down here, you can see the outside of the bowel wall and the inside of the bowel wall, because you've got air around both sides of the bowel wall, which highlights it and gives you the wriggler sign. And we've got this triangle of gas here as well. See here? Like, remember that I said bowel gas does not form, intraluminal bowel gas does not form triangles. So if you see a triangle of gas, you've got to raise the concern for pneumoperitoneum, and you can further confirm that with a lateral shoot through. Other lines that you may not be familiar with. So this is going to be a urinary catheter line here, and then I think that's it. And we've got the NG tube, and that's it. So these were all 3 cases of pneumoperitoneum, which can happen as a consequence of NEC, but also bowel obstruction, like Sam said, with atresias, etc., etc. So on the radiograph, we're looking for lucency overlying the liver. It also will then accentuate peritoneal ligaments. So you can see, sometimes you'll see the falciform ligament in the liver outlined by the gas. You'll see the football sign, which we saw in the first case, which is an oval hyperlucency, which sits underneath the anterior abdominal wall. And that's because you've got such a large volume of gas, it just rises and sits underneath the abdominal wall. You'll see triangle sign, which is pockets of interloop gas, which we've seen on 2 of the cases, and wriggler sign, which is where you see both sides of the bowel wall. The catheter in the previous image was a urinary catheter, so into the bladder. And we can do a lateral projection, like I said, so either a horizontal beam where the machine and the detector are at the sides of the patient, and you shoot the beam through the patient whilst they're supine. Or if the patient's stable enough, you can actually turn them onto their side, hold them there for a few minutes, and do a lateral decubitus radiograph, which is the most sensitive. And what you'll see on that image is that you'll see the air rising above the abdominal contents to sit underneath the abdominal wall. If you see peritoneal calcification on a radiograph, particularly in a neonate, it suggests antenatal perforation, so due to an atresia, like you saw in Sam's earlier cases. So this is just another example to show you a football sign. So this, if we had a proper abdominal radiograph on that earlier case, this is what you would see, this big lucency, and you can see that there's bowel loops in the abdomen, but there's this massive amount of free intraperitoneal gas. And then this is outlining the falciform ligament in the liver, just here. Okay, and then this just shows you the wriggler sign and that continuous diaphragm sign and that interloop pocket of fluid, as I've already mentioned. So we're going to move on to the next case. I don't know if I'm switching candidates or not, but maybe I'll give this last one to candidate 3 and then we'll change. So do you want to have a go at this case, candidate 3?
Okay. I have 3 images of ultrasound abdomen showing the pyloric canal of the pyloric canal. There is measurement in the for my left one. I see the thickness of thickness of the pyloric wall about 0.34 34 millimeter. The length of the canal about 2 centimeter. It is dilated. In the other view, I see the thickness also here, measuring total caliber and the length. So this all thickness of bowel pyloric wall more than 3 millimeter suggestive of congenital hypertrophic pyloric stenosis.
Yeah, perfect. So this that's exactly the case. So this is the case of hypertrophic pyloric stenosis. So here we've got the pylorus, we've got the stomach, which is, you can't see it fully on this image. This is pancreas, and then this is liver. And the pylorus normally sits between the pancreas and the liver, so I use that as my landmark for when I'm looking for them on ultrasound. And this will be a LS view, so a long view of the pylorus. And we can see that the single muscle thickness, so if you measure just the hypoechoic muscle to the edge of the hypoechoic region, is over 3 millimeters. The length of the pylorus itself is elongated, as candidate 3 said. And then when we do it in transverse, we get this donut sign here. The other things that I want to point out was with pyloric stenosis is when you're doing the ultrasound, often people will mistake the esophagus for the pylorus. And because you normally see the esophagus coming in here and heading towards the stomach. So if you can follow the structure into the chest, that's going to be your distal esophagus coming through your diaphragmatic hiatus. That is not your pylorus. You should be looking for your pylorus between the liver and the pancreas. And then what we should also be doing is trying to do a dynamic assessment. So I normally just put my probe on and watch to see if I can see the pylorus open. Normally you'll see that the stomach is distended with lots of gastric contents, and the pylorus won't open. So normally you'll see here, it should open, it should separate, and then you should see stuff passing into the D1. Sometimes I'll try and trigger this, so I'll give the child a feed, either water or milk or whatever. I'll ask them to give the child the feed either via the NG or orally, and watch to see if the pylorus opens, because that dynamic assessment really tells you is there a true stenosis or is everything due to pylorospasm, which I'll come on to. So this is an example of a normal pylorus, just for you to contrast to the abnormal. So this hypoechoic band here that you can see on both sides is the muscle, and that is what we're measuring. So just this hypoechoic structure here. And that is what becomes thickened in hypertrophic pyloric stenosis. So the single muscle wall thickness should be less than 3 millimeters. And this is the most accurate measurement, this one here, for pyloric stenosis. Normally, the transverse diameter, so that's if you measure across the entire pylorus, should be less than 14 millimeters. And then the pyloric channel length should be less than 15 millimeters. Some papers will say less than 17 millimeters, and I even read one paper that said less than 12 millimeters, but 15 millimeters is the most commonly accepted measurement for the length of the channel. And like I said, you can see that the pylorus should open on dynamic assessment for it to be a normal study. So this just shows you the measurement. So this is the trans diameter, so you can see that this is 11 millimeters, which is within normal. The single muscle wall thickness is 1 millimeter, and then I've not got a channel length measurement, but that was also normal. So this is our case that we saw. We can see that the muscle wall is too thick, so it's more than 3 millimeters. The channel is too long, so it's 21 millimeters rather than being less than 15, and the transverse diameter is not measured here, but this would most likely be more than 14 millimeters. And then this is another case to show you the thickened muscle wall. This is slightly over measured, but it's probably about 5 millimeters and 18 millimeters. Someone's asking, should the transverse diameter be measured without gastric content passing through the pylorus? I'm not too sure about that question. Because in a true pyloric stenosis, you won't see any gastric contents passing through the pylorus. And the transverse diameter, I don't tend to measure on the transverse image. I tend to measure just on LS, and I just measure those 3. Transverse diameter should be less than 7 millimeters. No, so the transverse diameter is across both. Oh, sorry, yeah, it should be less than 7 millimeters across both the wall. Is that what you're saying? I'm not sure. But it's the measurement from one wall across the middle and then across to the end. And yeah, so I think that is a typo. It should be less than 7 rather than 14. Oh no, each wall is 3 millimeters. I'll come to you at the end because I think I'm interrupting what I'm saying, answering your questions, and I'll double check the measurements to make see if we've put a typo in. And then on the rounded view, on the transverse view, I don't tend to measure the wall on a TS view. I tend to measure it just in the LS view, but you can still see that the muscle is more than 3 millimeters. So I just want to think I've got a video somewhere. So this was a case that I did a few months ago, where the muscle thickness is borderline. So you can see it's 2.5, so it's coming to the upper limit of normal, but it looks like what I would expect a pyloric stenosis to be. So all the measurements were just borderline going to the upper limit of normal, and the patient had a really convincing history of vomiting. And I think their gas was slightly off as well. They had a bit of metabolic alkalosis. But because it was borderline and I didn't see it open during the study, I really wanted to bring the patient back to confirm whether what I was seeing was truly pyloric stenosis or just due to spasm, pylospasm, because the child was upset and things like that. So I scanned them a few days later, so like a day, I think it was 2 days later, because they were clinically stable, and you can see that the muscle wall thickness is actually normal. And what we were seeing on the initial radiograph, the initial ultrasound, sorry, was just due to pylospasm, and I saw it open on the follow-up X-ray ultrasound. So here we can see it looks more normal than it did before. So you can compare the trans to the trans views. I thought I had a video, but I don't think it's playing. So we'll just go on to the next case, which is case 17. So do we want to change over? Is there a fourth candidate?
So candidate 4, are you with us?
Yes.
Over to candidate 4. Toby, thank you. Over to you.
Okay, so do you want to present this case?
Yeah, sure. Yeah. These are the selected images of the ultrasound of an abdomen. I can see on the left side there's a target sign, which are comprised by the bowels, and on the right, upper and lower, I think this indicates a pseudo kidney sign. Mm-hmm. So these are most likely to represent intussusception.
Yeah, correct. And then we'll move on. Okay, so as candidate 4 correctly spotted, we've got, so this is an ultrasound with the probe in the right upper quadrant. So this is your liver here. And we can see that we've got this, this is a transverse view. So we've got this rounded hypoechoic and then centrally hyperechoic structure, which is in keeping with our target sign that we see in intussusception, which I'll come on to explain. And then here we've got a LS view. So we've elongated out this structure and we can see this pseudo kidney sign. So here we've got a hypoechoic periphery and central hyperechogenicity, but we know it's not the kidney because we've got the kidney down here. So this is a pseudo kidney sign, and this is also a pseudo kidney sign, which I'll come on to explain. So the donut sign is because you get concentric alternating bowel wall layers. So you get the mucosa and the muscularis, and then you get hypoechoic bands. So the mucosa and the muscularis are echogenic, and then you get hypoechoic bands, which are the submucosa. And then that's what you see here. So you get alternating bands. You can see hyperechoic, hypoechoic, hyperechoic, hypoechoic, and then you get centrally in the middle, you get that mesentery that's been pulled in. And then with your pseudo kidney sign, you get a mimicker of a kidney. So basically the mesenteric fat centrally mimics the fatty hilum, and then the bowel wall mimics the cortex. And that's why it's called a pseudo kidney sign. And then as long as you see your kidney, you know that's what you're looking at. Or you turn TS and see this donut sign. So what we're looking for is, can we see any complications that will be contraindications to doing a radiological reduction? So we're assessing for vascularity. So I always put color Doppler on to see flow, and there should be flow in the mesentery and flow in the bowel wall, as we have in this case. I also look to see if there's any fluid within the intussusception, because that can make it a bit more challenging to reduce, or can suggest that there's a lead point, such as a duplication cyst. I look for free intra-abdominal fluid because that can be due to perforation. And I also try and assess for a lead point. So often in these intussusception patients, it's because they've had a viral infection of some sort. They've got enlargement of their lymph nodes, and the mesenteric lymph nodes act as the lead point. So you'll see mesenteric lymph nodes such as this within the center of the intussusception mass. Other lead points you may see are polyps or duplication cysts, like I said, or even a Meckel's diverticulum. And you may not see them on the initial ultrasound, but if you have patients who present recurrently with intussusceptions, or you have older children presenting with an intussusception, then just be aware that there might be a lead point. So this is just another picture to show you an intussusception. And then this is another picture as well. And here we can see it nicely shown. You can see this is the intussusception with the alternating layers. Play. This should play. See if I can make it play. Oh, okay. My video is not playing, unfortunately, but this was just showing you an intussusception on a video. It's not super exciting, so you're not missing out on anything. Okay, sorry, everything froze for a second. Okay, so that's ileocolic intussusception, and that's the most common type of intussusception we see, and that's the one that requires reduction. And I'll come on to reduction in a second. What we can also see is a small bowel, so ileo-ileal intussusception. And these can present in a similar way with colicky abdominal pain, child drawing up their knees, but they don't tend to present with the PR bleeding. So with the jelly-like stools that you see. So often when you're scanning, you can see a small bowel intussusception in the paraumbilical region or in the left side of the abdomen where you've got lots of ileal or jejunal loops. To help you differentiate between that and an ileocolic, normally the diameter on the AP, so on a transverse anterior to posterior measurement, is less than 1.5 centimeters, so they're smaller, and normally they're a shorter segment, and the hypoechoic wall is thinner because the small bowel wall is thinner than the colon wall. You will still see the mesentery centrally, but you won't tend to see lymph nodes within them, which helps you differentiate. And normally, even as you're scanning, they will disappear. So you'll scan, you'll see it, you'll take your images, you'll scan something else, you'll come back to that area, and it's disappeared, or it's in another different part of the bowel. And these ones, small bowel ones, do not require a reduction. So if you see a small bowel intussusception, you can just say it, tell the surgeons, but they don't require a reduction. Sometimes we'll repeat the ultrasound to make sure that they've resolved, or we'll repeat it if the patient's not clinically improving. So moving on to intussusception. Trying to make my videos play. I can't play my video. Oh, here we go. I just saw a thing flash up. Are you going to play? I can't make my videos play, but what I'll do is at the end, I'll get Sam to put up her slides, and we'll play the videos from her computer. So what we do in my practice is that we do an air enema reduction, so a pneumatic reduction. Some centres do a water enema reduction, but I think I and Sam, we both do pneumatic ones. And what we do is we do it under fluoroscopy, so we have real-time X-ray guidance because there's a risk of perforation. And so we put a catheter into the rectum. So I try to use as big of a one that I can fit in. So a 16 French is usually what I go for. And I put it into the rectum. And you can either do it with the patient supine or prone. I tend to do them prone because it means you've got some pressure on the abdomen and it helps maintain your intra-abdominal pressures to help your reduction. But some people do it supine. You have to keep the catheter in the rectum, so you either put a finger against the catheter at the anal verge, or you can inflate the balloon with a small amount of water, and then you insufflate the bowel with your air generating machine, whatever that is. And we normally do 3 attempts up to 3 minutes. We're starting with pressures at 80 millimeters of mercury, going up to 100 on the second attempt, and then on the final attempt we'll go up to 120, but some centres do 100, 120 for all 3 attempts, so it depends on what you do in your local practice. If I'm getting close and I'm on my 3rd attempt and it's coming to 3 minutes, I may go for a little bit longer, but generally 3 attempts up to 3 minutes is what is recommended. And you've got to continuously screen as you're insufflating the bowel because there's a risk of perforation. The other risks are you can not reduce it, which we can see sometimes. Sometimes you can get it to the ileocecal valve and you can't get the air into the small bowel, but the surgeons will still appreciate that because you've pushed it round for them. And then there's also a risk, I think it's about 10% of them recur post-reduction. So when the patients are consented by the surgical team, they need to consent for all of those things. I also get them to consent for bruising on the buttocks because you're squeezing you're getting someone to squeeze the buttocks to maintain your pressures, and that can cause bruising. Contraindications to doing air enema reduction include any features of perforation on the ultrasound. So if you see any mucky fluid or you see any free gas over the liver capsule, then that's an absolute contraindication. If I see ischemic looking bowel, I also won't attempt, and I'll have a chat with my surgeons. And if I think there's a lead point when I'm doing the ultrasound, you can have a discussion with your surgeon. Some would still like you to try because, like I said, you've pushed it round as far as you can and then it makes their operation easier, or some will take them straight to theatre. It's just a conversation to have with them. So I don't think any of these videos are going to work, so I'll show you this case at the end. So I'm just going to skip through these slides because these videos won't work. But it's a case where we had a recurrent intussusception, which I'll show you at the end. Oh wait, that video worked. How weird. Okay, anyways. So candidate 4, do you want to go on to this case?
Yeah. Okay, again, select the ultrasound images. Okay, I can see on the right side, there's a blind-ended tubular structure with alternating hyper and hypoechoic muscular bands.
Mm-hmm.
I think this, and on the left side, top left, is the transverse image of the previously mentioned tubular structure. I think this represents appendix.
Yeah.
The meter is 0.9 cm, which is thickened. So there's appendicular increased vascularity. Mm-hmm. So I think it's an acute appendicitis.
Okay. Perfect. So those are all correct findings. So this is your blind ending tubular structure, which is the appendix. It's not, I've not labeled the images very well for you, but this is in the right iliac fossa. You can also see that there's increased echogenicity of the surrounding fat. So take my word for it or see it. There is this fat around the appendix, the periappendiceal fat, is too bright. And then once we've measured it, it's above 6 millimeters, so it's nearly 10 millimeters, and there's increased vascularity, all features suggestive of acute appendicitis. So a normal appendix, so this is a picture of what the appendix should normally look like, is under 6 millimeters in diameter, so that's best measured on the transverse view. It's normally compressible, so you should be able to squash the appendix, and it's often got gas within it. And there is normally minimal to no vascularity around, minimal vascularity around the appendix and within the mesentery. And the surrounding structures are normally also okay. To find the appendix, what you should do, what I do, is I trace down my right hemicolon to my cecal pole. And then I look for my ileocecal valve so I can see my terminal ileum and make sure that's all normal and not the cause of their symptoms. And then at the bottom of my cecal pole, I should see my appendix coming off, arising from there. So this is an image to show you your cecum. This is, and this is your appendix coming off here. And normally the appendix is draped over the iliac vessels if it's in its normal position. So this will be your iliac vein, and you'll see your iliac artery, and you'll see the appendix just drapes over them. And then I normally just make sure there's nothing sat between the appendix and the psoas that could suggest a little abscess, and then do all my measurements. If I'm really struggling to see the appendix, I do a couple of things. So I try and press harder or less hard, because if it's compressible, you might be squashing it, or you might not be moving the bowel gas around enough to see the appendix. So just change your pressure. I also get my patient to go to cubitus and try and do bimanual compression, so one hand on their back and the probe on their front of the abdomen to try and move that bowel gas out of the way so I can see the appendix. And then sometimes I'll also get them to go and empty their bladder, because that moves things around, and then I can see if I can see the appendix as well. So lots of different tips and tricks you can try and find your appendix. When you found your appendix, if it's an appendicitis, you'll see that it's more than 7 millimeters in diameter, which you can see in this case. You won't be able to compress it. It'll be hypervascular, like we saw on the initial case, and it won't move. It'll be in a fixed position. And I find that if I can find the appendix really easily, so sometimes even with my curvilinear probe, if I'm just having a look in the pelvis and I see the appendix, it's more likely to be inflamed than not inflamed. And then you look for your surrounding changes in the right iliac fossa. So increased echogenicity of your mesenteric fat, which is due to edema and inflammation, any free fluid, any mesenteric lymph nodes that are reactive, and also look for any collections or features of perforation. And you need to be able to follow the appendix from the base all the way to the tip to be sure that it's completely normal. And if it's thickened, you want to follow it from the base of the tip to look for any disruption of the wall, which might suggest it's perforated. On the transverse image, this is called a target sign. So this is, you get a hypoechoic fluid-filled center of your appendix, and then you get your inner mucosal, submucosal ring, which are also hyperechoic, and then right around the outside is your hypoechoic area. So this is called your target sign, and then you'll see there'll be a halo of mesenteric fat around the appendix that's echogenic. Okay, so this is another example of a dilated appendix. You can see here it's fluid filled and it's got these alternating echogenicities. And like I said, it drapes over the iliac vessels if it's in its normal position. This is an example of a perforated appendix. So this is the appendix here. And remember what I was saying about following it from the base to the tip. So the base is up here and it looks normal. And if you just saw this bit, you would call it a normal appendix. But as we come down to the tip, you lose that integrity of the appendix. You lose the definition of the wall. And you can't really, if I ask you to point to the tip of the appendix, I think it would be a challenge. And then just at the tip, we now see this hyperechoic structure with posterior acoustic shadowing, which is in keeping with a fecalith, and that there is no appendiceal wall around this, suggesting that this is a perforation and the appendicolith is within the mesentery. And you can see that this fat around this area is very hyperechoic, in keeping with peritonitis. Okay, this is another example of a perforation. So here you can see we've got lots of echogenic fat. We've got fluid tracking through the mesentery with a fecalith. And then we've got reactive thickening of the surrounding bowel. So this is ileum that's thickened. And then this is a bit of sigmoid that's thickened as well. And then this patient actually also had a small bowel ileus, so they had dilated, fluid-filled bowel loops that were a bit thick-walled, and that was in reaction to all the inflammatory change that was surrounding that pelvis because of this perforated appendix. You can also get a retrocecal appendix, so that's where the appendix goes up and it goes towards the tip of the liver rather than going down into the pelvis. And that's why if I don't see the appendix in the pelvis, I will scan back up towards the liver to make sure I'm not missing any suggestion of a retrocecal appendix. So this patient actually had a collection by the tip of the liver. So this is a complex collection and abscess. And then as we scrolled through, we found the fecalith within it. And then this is all inflamed mesentery around and dilated bowel loops with an ileus. And they went on to have a CT because initially we weren't sure if it was due to the appendix. We weren't sure what was going on, and to get some more information for the surgeons. And I can't show you the CT because my videos aren't working, but the CT demonstrated a perforated appendix with a retrocecal, with a with a collection due to a retrocecal appendix. But you could actually see the collection better on the ultrasound than you could on the CT, which we'll show you when Sam lets me use her slides. And this is just to show you more of that collection down there with the fecalith. So moving on from appendixes, we're going to go through a few more cases. So candidate 4, do you want to go through?
Sure. So this is a frontal radiograph of the abdominal X-ray of a pediatric patient. I can see two oval shape rounded metallic density at I think it's in the stomach. So they are not stick to each other, and the shape. There's no sign of Pneumoperitoneum. Yeah, and the visualized bones and lungs are clear. So I think this is a foreign body ingestion in the child. Highly suspicious. These are batteries.
Yeah. Exactly. Go on.
Yeah, I mean button batteries. This is surgical emergency. I would inform these findings to the surgeon, and I need to remove it. Yeah.
Exactly. So these are ingested button batteries. So we've got 2 radiopaque foreign bodies, as candidate 4 has said, and I actually think they're within the distal transverse colon. I think this is stomach up here. Oh, my pointer's not working again. Don't know why that's not working. So I actually think they're within the stomach. So this is within the colon. So this is stomach up here, and then this is colon. Important negatives, like you said, are to look for any features of pneumoperitoneum to suggest perforation, and then I also look for any bowel obstruction as well. But this is a non-specific bowel gas pattern. So things that children can ingest include button batteries. They can ingest magnets, and in the UK we've actually recently changed in the last year. We changed our imaging protocol for magnets. So we used to do just a abdominal radiograph initially, and a chest radiograph if you saw nothing on the abdominal radiograph but were concerned that they'd ingested a foreign body, just to see where it was. And then if we saw a single ingested magnet on the radiograph, we would then do a lateral of the abdomen to look to see if there's multiple magnets, because you can get magnets that stick to each other and look like one single magnet on the imaging. So doing the lateral confirms whether you have multiple or a single magnet. And then because magnets like to attract each other, they try and join through the bowel wall, and they can lead to perforations. So it's important that you identify if there's more than one magnet, because it changes how they manage the patient. These are the first-line imaging for foreign bodies. Some people do them as low-dose fluoroscopy imaging. Some people do a proper radiograph. I personally prefer a proper radiograph with the initial X-ray, but it depends on your practice locally. And what you're looking for is a radio opacity or radio density that looks foreign, basically. So screws, magnets, anything that children can get their hands on, they seem to want to swallow. Coins is also a common one we see. And they can be anywhere within the respiratory and the GI tract. So if there's a very strong suspicion of a foreign body, you have to go hunting for it. So if the initial radiograph of the chest or abdomen is negative, then do a radiograph of the other part of the body just to see if you can find a foreign body. Signs, so this is someone who swallowed a screw, and it's down in their right main bronchus. Features that might suggest to you that there is a foreign body, but you can't actually see it, so it's not radio opaque, are on a chest x-ray, you can see air trapping. So basically what you'll get is a hyperinflated lung or part or lobe of the lung, and that will look more radiolucent than the other lung, because you've got air can go in, but it can't escape, so you've got air trapping within that lung. So if you ever see a hyperlucent hemithorax in a pediatric patient in particular, you have to raise the concern, the possibility of a foreign body, even if you don't see a radiopaque density. There are other different conditions that can give you a hyperlucent hemithorax, such as Swire-Johnson, but foreign body probably is the one we see most commonly. And the reason that the item may not be radiopaque is that if it's something like food, like a peanut or a grape, that you won't necessarily see on the radiograph. So just to be aware of these findings. And then when the foreign body's in the GI tract, it can be difficult to say exactly where it is. So I normally say it's projected intraluminally within the left upper quadrant or right lower quadrant, wherever it is, unless I'm sure it's definitely in that structure. And then depending on the foreign body, we may do serial radiographs to make sure that it passes through the GI tract. So this patient actually was one of those ones. So she swallowed 4 batteries. So these are AA batteries in the UK. So she swallowed 4 of them and was having serial x-rays to look for them moving on. So you could see they were initially together, 4 of them at the right iliac fossa. And then on her subsequent radiograph, obscuring the 5th battery, and 1 had progressed into the ascending colon and 3 were in the transverse colon, but 1 is actually here, and it's actually perforated through the bowel and ended up in an extraluminal position. And you can see that she's got pneumoperitoneum in the abdomen secondary to this. So she actually perforated. And normally with AA batteries, we don't tend to worry about them in the UK. We just watch them for them to pass. But they can erode through, as we can see in this case. So this, I think, are my final cases. So candidate 4, do you want to have a go at this case?
Yeah, sure. These are to select the frontal radiograph of the neonate. For left, I can see my
perforated. And not ended up in an battery here was not moving. It was just staying stuck. So she had a subsequent X-ray, which I've not shown you, which also showed that this battery here was not moving. It was just staying stuck here, and she was clinically deteriorating with worsening abdominal pain and fevers. So she went on to have a CT, which I can't show you, unfortunately, the video, but this is that battery here. This one is actually here, and it's actually perforated through the bowel and ended up in an extraluminal position. And you can see that she's got pneumoperitoneum in the abdomen secondary to this. So she actually perforated. And normally with AA batteries, we don't tend to worry about them in the UK. We just watch them for them to pass. But they can erode through, as we can see in this case. So this, I think, are my final cases. So candidate 4, do you want to have a go at this case?
Yeah, sure. These are to select the frontal radiograph of the neonate. For left, I can see multiple lines. And
Are you going to have a go at the lines for me, please?
there are some lateral cardiac lines, which are at the left apex and also at the right parasternal area. And then one line at the midline, up from the cervical spine until the lumbar spine. I am not very sure what line is this.
Okay. What do you think it's going to? So what line would you expect to go down the midline from the pharynx, down the midline across the diaphragm?
An EVD line, extraventricular drainage. I mean, for the...
No, just a common line we put in neonates.
Yeah.
So this is an NG tube?
Yeah.
Yeah.
NG tube.
So this is an NG tube.
Okay, so...
Within the stomach.
Okay, so if it's in the stomach, this would be a very distended stomach.
Yeah.
So other than that, I can see, I think there's a sign of Pneumoperitoneum, because I think there is a football sign in the abdomen.
Okay. What makes you think there's a? Describe where you're seeing it for me.
Because I think there's a lucency overlying the liver, as well as left lumbar region. So it somehow, I think it is comprised. It shows a football sign. Okay. Other findings. I can see some lucencies in the lower abdomen, which could represent a clump of bowel loops, and also
which side of the lower abdomen are you seeing those?
On pelvic and as well as the right lumbar region.
So here?
This area.
Okay, so this is the stomach.
Oh, this is the stomach.
Because it's got the NG tube in it.
Okay. I don't see, other than the stomach gas, I don't see any bowel gas in the abdomen. There's a lack of rectal gas as well. Okay. So maybe the stomach seems continuous with the structure on the right side of the abdomen, which could be externally from the this patient's abdomen. So
what do you think is going on?
I think the bowel loops is extruded from the abdomen.
Exactly.
So this is the gastroschisis.
Okay. So I think it is quite a confusing radiograph, and you kind of have to, if you've never seen one before, you have to really think about what you're looking at. So the first clue, I'm going to come back to that. What I'm going to say is, on this one, you can see that this child has right upper lobe collapse, and I think it's because the NG is a little bit low, and then they've pulled it back, and that lung bit of lung is reinflated. So that's why your lines and tubes are important. But then the next clue for something not quite right going on is this NG tube. So normally where you saw our NG tube coming down the midline, bisecting the carina, which it does here, so it follows the course of the esophagus, it bisects the diaphragm, and then it normally comes to the left upper quadrant. But here you can see it's abnormally located, and it keeps coming down the midline, and the gastric bubble is abnormally located. So that suggests that the stomach is not where we would expect it to be. And then here we've got all this abnormal opacity with some areas of lucency, as you described, which represents the extruded abdominal contents. So this is a gastroschisis or an omphaloceal, but often we can't tell the difference on imaging unless we know it from the antenatal diagnosis or from when the child is born. But yeah, so this is a herniated bowel wall contents through a defect in the abdominal wall. So gastroschisis is normally affects the bowel, and it's rarer to have the stomach and the bowel and the liver, also herniated through, unlike an omphaloceal where you often get herniation of the liver primarily with or without bowel. So the gastroschisis herniates into the amniotic cavity because there's a defect in the paraumbilical region, the abdominal wall. And the difference between that and an omophilocele is A, where the defect is. So the omophilocele defect tends to be at the base of where the umbilical cord inserts, whereas the gastroschisis tends to be paraumbilical. And then the gastroschisis tends to have no peritoneal membrane around it, whereas the omophilocele does have a peritoneal membrane. But we often can't tell the difference between these two things on imaging. So we rely on our antenatal diagnosis and the surgeons. So it normally, the defect's more often on the right than the left, but that's by the by for us when we're looking at imaging. But there are associated anomalies, primarily with omophilocele, that we have to consider because they tend to be associated with abnormal chromosomal conditions or syndromic conditions, and you can get multiple organs being affected, so like kidneys, cardiac, etc., etc. Whereas with the gastroschisis, abnormalities are rare, but they mainly, if they do occur, they affect the bowel, so, because the bowel is the primary organ that herniates. So you'll get intestinal atresias. You can often get malrotation with both conditions, or you might get some stenosis of the bowel because you've had vascular compromise and areas of necrosis. If the peritoneal membrane ruptures on a omophilocele, it's difficult clinically to differentiate that from a gastroschisis. So you might look at what contents have herniated through, basically. So this is a gastroschisis, and then this is an omophilocele. So this, you might say, looks like it's more contained, more globular. So you might think that there's a membrane holding everything together, which points you to an omophilocele. But generally, our clinical teams have already decided what it is, and we just say there's herniated bowel contents. And here you can see all the bowel that's come through. So that was quite a lot of acute abdominal presentations / some not so acute that we've covered. So well done, candidates 3 and 4. So we've had esophageal atresia with tracheoesophageal fistulas, and we've looked at repulcal tubes, which is the double lumen blind ending tubes that's put into the proximal esophagus to help drain it. We've talked about VACTERL associations, so vertebral body anomalies, anorectal malformations, cardiac anomalies, tracheoesophageal fistula, esophageal atresia, renal anomalies, and limb anomalies, with it being important that you review the initial radiographs to look for the vertebral body anomalies, the cardiac anomalies, and the limb anomalies, as well as identifying the esophageal atresia and the tracheoesophageal fistula if one is present. And then they'll go on to have renal ultrasound to look for the renal malformations, and the anorectal malformations should be diagnosed clinically. We've talked about necrotizing enterocolitis, so we're looking for non-specific signs on radiographs, which include dilated thick walled bowel loops, or non-changing bowel gas patterns, or distended bowel loops, as well as more specific signs, which are pneumatosis intestinalis, portal venous gas on the plain film, and pneumoperitoneum. And also the importance of the use of ultrasound in necrotizing enterocolitis, primarily for follow-up rather than diagnostic imaging, and it having similar features as we see on the radiograph. Pneumoperitoneum, looking at all the different signs on a supine abdomen, which include football sign, which is air beneath the anterior abdominal wall, regular sign, which is where you see both sides of the bowel wall due to gas being on either side, continuous diaphragm sign, which is where you get gas in the upper abdomen outlining the diaphragm, and outlining of the peritoneal ligaments, such as the falciform ligament, as well as triangular pockets of gas. If you ever see a triangular pocket of gas, it's not bowel. Be suspicious for pneumoperitoneum. We've talked about foreign pyloric stenosis as well, with the single muscle wall thickness more than 3 millimeters being the most crucial. And to answer the question earlier, the diameter should be less than 14 millimeters. I've double checked it whilst I was doing this presentation. It's less than 14 millimeters, because the single muscle wall is not the only bit that contributes to the diameter. So you've got the different layers of the wall outside of the muscle, plus you've got the channel in between the two walls. So it should be less than 14 millimeters. And then we talked about the target sign as well on the transverse ultrasound. We've talked about Intussusception, and I'll try and show you those videos if we get some time at the end. Looking to see if we can find a lead point which will make reduction more difficult and may necessitate surgery. And then acute appendicitis, so looking for any complications of appendicitis such as perforation, collections, and appendiceal masses. So I didn't really talk about appendiceal masses. They're just basically really inflamed mesenteric fat, and then you see stuff stuck down to it. So you might get the appendix stuck down. You might see the bowel, the surrounding bowel loops also stuck down, and it just looks like a big inflammatory mass that's got increased vascularity, but there's no collection component to it. And both collections and appendiceal masses tend to be managed conservatively in my trust. And then we've looked at anterior abdominal wall defects. So the radiographs aren't to diagnose gastroschisis or Montflacil. That's when you diagnose clinically. The radiographs are to look for any bowel dilatation, which you can see if there's a concurrent atresia or there's been a stenosis. And then they're also to just, often they've put lines into the patient, so we're doing it to look at the lines. And not often they'll have already repaired it before they've even done the initial radiograph, but those were just some good cases to show you if you've not seen them before, because they could come up in exams. All right, I've been talking for ages.
And also there's one more thing. So in gastroschisis, because it's just bowel, right? Often, I think one of the pictures that Toby has, they also put what we call a silo. So it's just a plastic covering over the, so that's the case, which can make it hard to differentiate between omphalocele. Of course, you can also look for what's herniated within. So if you've got, more gas-filled bowel loops, there's bowel, and omphalocele, there's liver. So it can be easily said, there might be something else rather than bowel. The other thing that they might want you to do is to do an ultrasound and see exactly what's herniated, and you can help to characterize it further.
Oh, I've never had to do an ultrasound, so that must be a Sam thing. Okay, final few slides. I might just talk through these because I think it's I've run out of candidates, and it might just make things a little bit quicker because we're coming to the end. So we've got 2 liver cases to show you. So neonatal jaundice is complex. There can be lots of different causes, but one of the causes can be biliary atresia. And basically there are 2 key signs that we look for when we're assessing for biliary atresia. Number 1, you have to make sure before you start anything that the patient is well fasted. So we want at least a 4 to 6 hour fast for the patient, because gallbladder assessment is really important. So the first thing we're looking for is the triangular cord sign. So this is at the division of the portal vein. So I normally look along the right main portal vein, and we're looking to see if you can see a hyperechogenic structure. So normally there is a bit of hyperechogenicity, but if it's more than 4 millimeters, then that suggests that you've got a true triangular cord sign. And basically that's due to the atretic ducts that occur in biliary atresia. That's what you're seeing, the fibrotic atretic ducts alongside the portal vein. So this is the most specific sign for biliary atresia, the triangular cord sign. The other signs that complement the diagnosis are if your gallbladder is abnormal. So you can either get an absent gallbladder, you can get a small gallbladder, you can get an irregular gallbladder. If it's less than 2 centimeters in length, then that suggests that your gallbladder is small. And this has to be on a well-fasted child. And if you see any irregularity of the gallbladder as well, then that suggests that your gallbladder is abnormal, which ties in with the diagnosis of biliary atresia. And then this picture just shows you the triangular cord sign on a transverse image, but I normally measure it on another transverse image, which is where I normally measure it. So biliary atresia is a congenital absence or severe deficiency of the extrahepatic biliary duct. So often it's non-syndromic, so it's just an isolated atresia of the bile ducts, not related to any other conditions, but it can be syndromic, causing lots of congenital anomalies such as polysplenia or asplenia. They can get heterotaxy, which feeds into the polysplenia, and then they can get intestinal malrotation and interrupted IVCs and things like that. And the most common presentation is a conjugated hyperbilirubinemia. So I always struggle to pronounce that word. So they get conjugated raised bilirubin rather than unconjugated, and the concern is that they've got biliary atresia, and we need to pick it up as early as possible so they can go on to have the Kasai procedure, which prevents them going on to develop cirrhosis. So ultrasound is the first line imaging, as I've said, and we're looking for those atretic fibrotic ducts, bowel ducts, which is the triangular cord sign, and we're looking for the abnormality of the gallbladder. So often with biliary atresia, with biliary atresia, you do not get intrahepatic duct dilatation. So if you have intrahepatic duct dilatation, then it's unlikely to be biliary atresia. And if you are concerned for biliary atresia based on the ultrasound appearances, you can do a HIDA scan, which is a nuclear medicine scan, which looks for uptake of the radiotracer and then excretion into the gallbladder and then eventually into the small bowel within 24 hours. But the definitive diagnosis is done by a biopsy. So if it's picked up early enough, they can have this thing called a Kasai procedure, which is where they do excision of all the fibrotic abnormal bile duct tissue and then do a Roux-en-Y anastomosis of the intrahepatic ducts to lead to the jejunum. So that's how you get your biliary drainage, basically via this Roux-en-Y jejunostomy. If it's caught late, or if the patient goes on to develop cirrhosis and ends up in liver failure, then they can end up needing a transplant, and it's the most common cause of transplantation in the UK and in paediatric patients is biliary atresia. So this is just a bit more about your gallbladder ghost triad. So you get a small gallbladder, so less than 2 centimeters is what I have in my head. And you get irregularity, which is due to thinning or absence of the echogenic mucosal lining. So you get irregularity, and then you also get thinning or absence of the echogenic mucosal lining. So you can see here we've got a very small gallbladder. It's really irregular, and you don't see that mucosal lining as well. And then if we compare it to a normal gallbladder, you can see it's not irregular, and you can see that mucosal lining very well, as you can see in these pictures. So this is your gallbladder ghost triad. Other features that you can see on ultrasound are you can see a dominant hepatic artery, because that is the main supply to the bile ducts. And then you get hypertrophy of the hepatic artery, and it becomes the dominant. So you might think it's the portal vein because it's so big. And then this just shows you a HIDA scan. This shows you an MRC. This image, we're moving on, shows an MRCP study, which shows a colodocal cyst. So this is a dilated CBD, and this is your gallbladder, and this is your cystic duct, and this is abnormally dilated. So in a pediatric patient, I normally have up to 2 millimeters as my cutoff for normal caliber CBD. I allow up to 3 in the teenage children, but about 2 is my cutoff for normal CBD. And you can see here, this is just further MR images to show. So this is the gallbladder here, and then this is that dilated common bile duct. So colodocal cysts, there's 5 different types, and the one we saw on the previous imaging was the type 1, where you've got dilatation of the common bile duct, and it's based on a Todani classification, which is a little bit controversial because the surgical literature says it may not accurately define the different types and the different disease processes that are going on, but this is the one we still commonly use in imaging. So you can have type 1, which, like I said, is the common bile duct. You can have type 2, which involves your cystic duct. And then depending on the involvement of your intrahepatic ducts, can upstage you into type 4, type 5. 60% of colodocal cysts are diagnosed in the pediatric population, particularly under the age of 10, although it can be asymptomatic and you can be diagnosed as an adult. It can be associated with biliary atresia and hepatic fibrosis, which tends to be the type 5, where you get intra and extrahepatic duct dilatation. The exact etiology is uncertain, so no one knows the pathophysiology behind colodocal cysts, but they're just the other cause of neonatal jaundice to be aware of. And like we would see on the MR, what you see is a dilated bile duct or cystic lesion that communicates with the bile duct and is separate from the gallbladder. And then they'd go on to have MR imaging to clarify the anatomy prior to surgical management. So those were 2 quick liver conditions, just so that you're aware of them. So biliary atresia and colodocal cysts, which cause neonatal or childhood jaundice. Biliary atresia, the 2 key features are triangular cord sign and gallbladder ghost triad on ultrasound, with HIDA scan as a supportive examination, but biopsy being the definitive medium to make the diagnosis. And the necroleudocal cyst is due to a dilated cystic lesion communicating with the biliary tree, which is separate from the gallbladder on ultrasound and cross-sectional imaging. So I think that's the end of the Okay.
Yeah, this one.
Yeah, so so this is the first case. So it's a chest X-ray of a neonate, and you can see here. This is the Sam. Can you point out the NG tube for me, please?
No problem. There we go.
So that is the coiled NG tube in the proximal esophagus. So normally it should pass down, bisect the carina and end up in the stomach, but it's coiled because the esophagus is atretic. So you've got no communication between the proximal esophagus and the distal esophagus. And then we know there's a tracheoesophageal fistula because there is gas within the stomach. So the only way for gas to be in the stomach with a basically atretic esophagus is if there is a fistula between the trachea and the distal esophagus, and then gas goes into the stomach from there. So this is TOF/OA. Can you flick to the H-type fistula type image? The fluoro study.
Yep.
Sorry.
No. So
this is this study is looking for a H-type fistula. So what we do is this is the way I do it. We do like an esophagram. So you have your NG tube in the esophagus, and then you inject contrast into the esophagus. And what I do is similar to how I do my anastomotic leak ones post-repair, is I gently pull back on my NG tube as I'm injecting contrast and see if I can see any contrast going into the trachea. And I do them in a right lateral position to try, or slightly oblique, to try and lift the trachea off the esophagus. And then what you're looking for is a little fistulous tract, and then contrast pacifying the trachea, which it shouldn't normally do. You have to be careful not to pull your NG tube too far back, because you can end up in the pharynx and then they're aspirating, and that's why you're outlining your trachea. But that's how I do them. Do you do them any differently, Sam?
No, I think in my trust we don't do tube esophagams, so we just do a routine swallow, because the surgeon say that. Yeah, and the reason why I think unless it's a very big defect, then they will be worried. And that's the reason for the tube esophagram, because you want to give enough pressure, because some small tracts can be opacified with a normal swallow, because the pressure is not high enough. So which is why you want direct injection of pressure. Yeah.
So I think we do them in the recurrent aspirations, chest infections, the ones where we're looking for a really small tract. We'll do a tube esophagram, as Sam has suggested. Okay, would I prefer use of diluted barium over water-soluble contrast media to evaluate postoperative TOF? Nope, I would still use water-soluble contrast media. A lot of these kids haven't eaten, so there's a risk of aspiration. They've had a Repulgal tube since birth. Post-repair, they've had an NG tube. Their swallow mechanism hasn't really been tested. I would still use a water-soluble contrast media. And also, if you get an anastomotic leak, it's less irritable using water-soluble contrast than barium to the surrounding structures. So can you go to the NEC X-ray, please?
Yeah, sure.
The first one.
Yep.
So it's quite subtle, and we can't window, but this, as Sam is pointing out, is the area of abnormality. So if you look at the wall of the bowel, you just get the impression that there's more bowel wall there than there is when you look at other loops, which suggests that the bowel wall is thickened. It's quite a subtle abnormality, and you'll pick it up the more you look at neonatal radiographs and what to expect and what to see. I think I did highlight the Pneumoperitoneum, so I'm going to skip that question and skip the sign in the previous ones. And I've answered that question about the catheter, and we've done the pyloric stenosis question. Okay, so when I do ultrasound for pyloric stenosis, I image them supine. I do all my imaging supine. Some people will put them in a left lateral decubitus position to try and see the stomach better. Left lateral? Do I mean left lateral? In a
right lateral.
Right lateral decubitus. That's why I paused. I was like, that makes no sense. In a right lateral decubitus position to try and see the pylorus better. But also what it does is it tends to encourage the stomach to empty, similar to what we do in an upper GI contrast study, putting them in a right lateral position. But I tend to do mine supine because I find I can see what I need to see supine. When should we give pylorospasm as a differential diagnosis? I would suggest any ones where the pylorus looks at where it's starting to measure at the upper limit of normal for single wall thickness. So once it's getting over 2.5, coming to 3 millimeters, I would suggest that because it's not abnormal enough to call it a definite pyloric stenosis, But what I would do is in my report, I would say this is measuring towards the upper limit of normal, and I've not seen, if I've seen the pylorus open, that's fine, it's normal, the pylorus open, move on. If I've not seen the pylorus open, I'll say this is towards the upper limit of normal. I've not seen the pylorus open, we should follow this up. So I'd repeat the imaging in a few days and just have another look to see, because if it's pylospasm, I shouldn't see an abnormal pylorus again on the second ultrasound. If it's up towards the upper,
No, sorry, I was just going to say also, just remember that these measurements are arbitrary, because you don't know when people came out with these terms. Were they done in term babies? Were they done in preterm babies? You know, everyone's, we know that I think if they've got higher body weight, or that's what literature says, then your measurements can also change because they'll be thicker to account for it. So let's say you've got a very premature baby and you're trying to use these measurements, they can actually have pyloric stenosis even though they don't meet these measurements. So it's really a dynamic examination rather than the measurements this, it is definitely this kind of thing. Yeah,
so definitely you have to watch to see if that pylorus opens. And we get referred stuff from around the region where people haven't seen if the pylorus opens or not, and often we're repeating the imaging to see does the pylorus open. Often when you see the pyloric stenosis, the stomach's really distended and you'll see the stomach contracting, but nothing will happen at the pylorus, which adds confidence that it's a true pyloric stenosis. And I find that we're diagnosing it younger and younger now. So it used to be 6 weeks was the typical age of presentation, and now we're doing it in 2-week-olds. So like Sam said, you have to look for that dynamic assessment. So I've done contraindications. How I find the appendix, so I do graded compression. So I keep the probe, I use a linear high frequency probe. I do graded compression down the right side of the abdomen, so down the ascending colon until I find the cecum. And I try and, instead of lifting my probe on and off the patient, I try and keep the pressure there, because if they're peritonitic, lifting it on and off is going to irritate them and they're not going to want you to scan them. So I keep my probe in the same position and I just gently move it down the abdomen, keeping a good pressure, trying to dispel those bowel loops. I might stay in one position for a little bit of time to try and encourage the bowel to dispel, the bowel gas to dispel away. And then I'll move my probe down, find my cecal pole as my anatomical landmark. Go forwards 2 slides for me, Sam, maybe 3 to show the anatomy. Find my cecal pole as my landmark, and then I will look for my ileocecal valve, because I always check my terminal ileum in all these patients. And then just inferior to that, you should see your appendix draping over your psoas and your iliac veins and artery. And then it should be blind ending. Some of them can be quite long, so just make sure you follow it all the way from the base to the tip. And if you can't see it all, put that in your report, because calling an appendix normal without seeing the whole appendix can mean that you're missing an appendicitis. If I can't see it doing that, then I'll do either turn the patient obliquely, do bimanual compression, or get them to empty their bladder. Those are the little things I do on top. Where else are we? I'm losing track of all the questions. Okay. Yep. Repulgal tube is just it's a double lumen tube that they put in so they can drain the esophagus. So I think we've got a picture on maybe the second case. Keep going. There, that's the repulgal tube. So you can tell it's a repulgal tube because it's got the interrupted radio dense lines. So they're interrupted. So you've got a hole between them. And it means that they can aspirate, and also they can put saline in as well. So it's double lumen. So they can suction from it to drain the secretions that the child has swallowed. But they can also inject into it as well by putting some saline in. And the saline helps break up the secretions so that they can then aspirate them. So we've done that. Done the first NEC X-ray. In HIDA, how can you differentiate between neonatal hepatitis and biliary atresia? Didn't we have this conversation? I think I had this conversation with my regis yesterday. So it can be very difficult, and you can't necessarily differentiate between them on HIDA scans, and that's why biopsy is the definitive diagnosis. So if the HIDA scan is abnormal, in that you don't see any excretion of the radiotracer into the bowel after 24 hours, I would normally just say the HIDA scan is abnormal. The differential for this is this, this, and this. Particularly, for example, if they're on TPN, total parenteral nutrition, that can give you an abnormal HIDA scan. And then they have to make the decision, whether they need to send this child to a liver centre for biopsy. So you can't necessarily differentiate between the two on the HIDA scan. And which contrast is given in H-type fistulas? Omnipaque, water-soluble omnipaque is given, or other water-soluble contrast. So I think those are all the questions.
Do you want me to do the videos?
Now we've only got 3 minutes, so maybe we'll just leave it. What do you think, Dr. Khan?
Sure. Oh, I just show it since we are here. It's quite fun to show the video.
I think Sam, go ahead.
Go ahead. Okay.
Yeah, go ahead.
All right. So I'll tell you.
So, first one.
Yeah. So this is an intussusception. So this is just a video. I love taking videos. I love cine loops. I know Sam loves cine loops.
Yeah.
I find that, especially now I'm a consultant, I'm trying to review a registrar's ultrasound. Sometimes I'm like, I don't know what you're looking at. But if they've sent me a video of what they think is abnormal, I can easier dismiss or confirm the abnormality. And I take videos for myself because sometimes you've not noticed something as you've been scanning, and then when you go report it, you see the video and you see the abnormality. So this just shows you an intussusception. So you can see this is in a transverse view, and you can see that you've got the large bowel here, and then the pulled in small bowel, and then you can see the echogenic mesentery in between the two layers. And then if you scroll through the video,
yeah, once again, I need to start it again. Yeah.
And then you can see the little lymph nodes, which are likely the lead point going into the intussusception. I think that's it, really. It's just a nice video that shows it all the way through.
Next one is this one, the reduction one.
Okay, so this is a reduction. It goes very quickly. So we'll just play it a couple of times. So this is the catheter into the rectum, this line here, which Sam may show.
Yeah.
And then this patient is supine, this patient is prone, so we're seeing gas pacifying the rectum and the sigmoid, and you can see that there's a filling defect. If you go back to
once again.
So the filling defect here is your intussusception mass, and you can see it's in the transverse colon, and then it's been pushed round as we're insufflating the bowel with air. It's been pushed round. This is someone's hand because they're trying to hold the child still. And it's been pushed down and round into the hepatic flexure now. We're coming down into the ascending colon and into the cecum, and then we're pacifying small bowel loops, which shows that we've successfully reduced the intussusception. We do ours under sedation, so we give Oromorph or oral sedation to try and make the child calm, and we only do it in children, in very young children. Anyone who won't who's too big or won't react to the sedation, we don't do it. So I think our cutoff is about 2 to 3 years old. Okay, so this was the case that I wanted to show you. So this child presented with an intussusception, classical history, saw it on ultrasound, confirmed it was all the way to the left upper quadrant by the time we scanned it. Often we just see them at the right upper quadrant by the liver, but this had gone along the transverse colon as well. We did the reduction.
Sorry, Toby. These two don't seem to play on mine either. So apologies for that. I think there was something.
Okay.
Sorry about. Yeah.
So we did the reduction, and it was reduced really nicely, and the child went home. They represented, I think, a week later with another intussusception, and we know 10% of them can recur. So we did the ultrasound, saw another intussusception. We did the reduction, but on the second reduction, as you follow it through, so the child is prone again, you can see that we're reducing it. You can see this filling defect, and you'll see it go into and then we're pacifying the small bowel loop centrally, but we still have a filling defect within the cecum. So there's still an area of abnormality within the cecum. So is this the potential lead point, and that's what's caused this child to represent with their intussusception? So there's the small bowel loops are pacified, and then we've got this filling defect that persists. And if it's a true reduction, you shouldn't have any persisting filling defects. So we go on to do an ultrasound. So if you go to the next slide, does that play? That might not play.
Wait. Oh, this is the one that plays. No, doesn't play.
Okay. So this is just the filling defect, and I've got some static images, and this child ended up having a colonic polyp. So this is the polyp seen within the cecum with increased vascularity, and that was the diagnosis, and that was their lead point. And interestingly, they'd actually been sent home after the second one because the surgeons didn't believe us that there was a lead point, and then they wanted a follow-up ultrasound. And on the day of the follow-up ultrasound, she had another intussusception, but was asymptomatic. And then that's when we identified the polyp as the lead point. And then she had to go to theatres to have that polyp resected and to have her intussusception reduced. So that's it. Those are all the cases. Thank you very much. It's been a long session, but hopefully you've learnt some things and found it useful going forward. And if you could please fill in the feedback form, because we've got 3 more of these sessions to do, and we can make some changes prior to the other 3, then that would be great. Thank you so much.
Thank you very much, Toby and Sam. Brilliant, absolutely brilliant. Some of these cases, have rekindled my love for pediatric radiology. Maybe I should now do it once again. So beautiful cases. And a beautiful comment I received from, your candidate for him, this is 5 a.m. in morning. Can you imagine? And he said it was worth the sacrifice, so he's learned a lot. So well done.
You did great considering you haven't slept.
Yeah. So thank you very much, and hope all of you will join us next week. The feedback QR code is there. So please, those of you who have joined us first time, please remember that